भाई मेरी मीटिंग चालू हो रही है, मैं अभी नहीं बात कर पाऊंगी। हाँ। हाँ। हाँ, but I cannot see right now, not possible. Can't speak right now. So we are live now. Sujayasri, over to you.
Yeah. Welcome to all the faculty and delegates to Searchlite 40. This is updates on liver disease in pregnancy. This program is being conducted in association with Cancer Prevention and Relief Society, along with OB-GYN societies of Raipur, Bhimavaram, Ahmedabad, Patiala, and Jalandhar.
Now I would like to introduce my convener, Dr. Sujayasri Sangita. She is a consultant obstetrician and laparoscopic surgeon, Sheshadri Hospital, Palakol, and Sheshadri Hospital, Malikapuram. She is also the founder secretary of Bhimavaram Obstetric Gynec Society, secretary of IMA Palakol. She has the Shan S. Ratnam Young Gynecologist Award, Foxy Dhira Award. Her areas of interest are laparoscopy and infertility. And now I think combined with me, she's become interested in everything else. She has paper presentations at AICOG, Yuva Foxy. She's been organizing secretary of GUSA 2016 and 18. She's been conducting awareness programs, Vikasam for adolescent girls, and it has been recognized by the District Lions Club. Sujaya has been the convener with me since Searchlight 6. So welcome, Sujaya. I'm really happy to have you here.
Ma'am, thank you for that kind introduction. It's been a great honor to be associated with you for so many academic programs. So moving on, I would like to introduce the program director, Dr. Asha Jain, ma'am, who honestly needs no introduction. She is the director of SMSA Hospital Raipur, medical director, Cancer Prevention and Relief Society, elected member, Chhattisgarh Medical Council, CP elect, that's a chairperson elect for Foxy, Food, Drug, Medical Surgical Equipment Committee, President Raipur Menopause Society, Chairman Mission Pink Health, IMA Raipur, Executive Member of ISCCP, Chhattisgarh ISAR Chapter and Chhattisgarh SFM Chapter. Madam has received colposcopic training. She has also received...
I think Sujaya, we stop with that. Yeah, hopefully all of us know. So I would like to add that my areas of interest are ultrasound training, colposcopy training, and also preserving the uterus. So with that, we proceed to take the... Dr. Purvi Agrawal, an executive member of Society of Fetal Medicine, Raipur, is also associated as a convener, and she's been helpful in getting me SFM speakers and good panelists. So welcome Purvi. And our guest of honor today is Dr. Bharti Maheshwari ma'am, who is the past chairperson of MTP committee. She is professor and head Department of Obstetrics and Gynecology and IVF at Muzaffarnagar Medical College. Diploma in IVF and Reproductive Medicine from Germany. Chairperson Foxy MTP Committee 2018 to 20. Fellowship in Medical Education by MCI FIME. Governing Council Member ICOG. Secretary UP President Meerut Obstetric Gynec Society. Author and editor of many textbooks of obstetrics and gynae. He has published papers and review articles in index journals, delivered Kamini Rao oration and other talks in national and international conferences. He has organized the North Zone and UP conferences as the organizing secretary. And she is also the national coordinator MTP committees 2015 to 18, executive member endocrinology committee, public awareness committee, and medical education committee. So I don't see ma'am. Probably she would be busy and would join later. We would start the academic program. So our speaker is Dr. Munjal Pandya. I met him in a conference recently in Kanchipuram, and his way of presentation was something very unique, and I really loved him for it. He's also going for chairperson medical education committee in the coming year. So I will leave it to Dr. Ruche to introduce him, and I would request Sujaya, would you introduce Ruche ma'am?
Yeah. So Dr. Ruche Bhargava ma'am has been associated with us in numerous programs, so it's an honor to have you with us, ma'am. Currently, she is the consultant and director at Bhargava Advanced Gynec Surgery Cancer Center. Her special achievements are she's been the past secretary of Foxy Jalandhar, chairperson academics Foxy Jalandhar, patron of PCOS Society, and also has been a faculty at numerous national and international conferences. So it's nice to have you with us, ma'am. And I request you to please introduce the speaker, Dr. Munjal Pandya.
Sure.
I would like to add here that Dr. Ruche is my go-to person when I'm searching for topics or speakers. And, you know, she's always delivered. She's helped me and kept my morale high, even during the election when I was sometimes down. So thank you, Dr. Ruche, for being with us yet again. And over to you to introduce Dr. Munjal.
Thank you very much, Dr. Asha Jain and Dr. Sujayasri. And it is always a pleasure to be associated with this program. And that is why automatically this comes from inside that I should help you whenever you need help. And in the past as well as in the future, I shall be with you. It's a pleasure to introduce Dr. Munjal Pandya. He's Associate Professor, Narendra Modi Medical College, Ahmedabad, Gujarat. An FICOG Diploma in Minimal Invasive Surgery from Kiel. Honorary Treasurer of Ahmedabad Obs Gynae Society for the year 24-25. Honorary Secretary of AOGS for the year 21-22. He's received the Shirish Daftari Young Talent Award from AOGS for the year 2017-18. Co-edited a book on male infertility in January 2019. Winner of the Dr. Kamini Rao West Zone Yuva Foxy Oration for the year of 2021. Published many papers and chapters. Authored Gujarati and English photo books. Self-published in September 22 and 24 respectively. His hobbies are he loves painting, guitar, singing, writing, tennis, photography. Dr. Munjal, it's a real pleasure to have you with us, and I'm looking forward to your deliberation.
Thank you so much, ma'am.
He has recently released a book.
Yes.
Okay.
Yes, yeah, thank you so much. Thank you, Asha ma'am, and whole team for giving me this opportunity. It's a topic which usually an obstetrician would refrain from managing on his own or her own. But I would try to bring in some insight that we already know, and I would just like to brush up on the knowledge with regards to liver disease in pregnancy. Asha ma'am, many congratulations, first of all, because the way I have seen this past 5-6 minutes, you have a team of like-minded people who would be working hard and have been working hard for academics. And it's very, very rare to see the promotion of academics in such a beautiful manner. So many, many congratulations, ma'am and whole team for organizing this Searchlite for the benefits of a lot of people maybe who have done their post-graduation since long, and those who are doing at present as well. So many congratulations, ma'am, for the same. So to begin with, liver disease in pregnancy, we know that pregnancy brings in a lot of physiological changes. We are aware of all those changes. Just to brush upon the basic knowledge of that physiological changes. So in case of, if we say that a patient might have spider angioma, most of the times in non-pregnant state, we would like to, stamp that she might be having some liver disorder. But in case of pregnancy, the spider angioma might be a normal finding. On right, we see the pattern or the image of spider angioma. Same goes with Palmer arrhythmia. Now, both of the changes are routinely seen in non-pregnant state only if there is some kind of liver disorder. But in pregnancy, they get normal, so physiologically they can be present as well. So keep in mind with regards to this two physical findings, which might be normal during pregnancy. We all are aware that there are a lot of physiological changes in pregnancy, right from cardiovascular system to cardiorespiratory system to blood volume changes to the blood cell changes. But when it comes to biochemical investigations or the blood investigations, there are a lot of changes with regards to trimesters. So if I say that all the liver enzymes may be in normal or a little reduced range, there is one enzyme that is alkaline phosphatase. It gets erased with the increase in trimester. As we can see, the normal range in non-pregnant state would be 33 to 96 units. But in case of first trimester, it is slightly in range, but in second and third trimester, it will keep on increasing. So if the patient comes to you with a slightly raised alkaline phosphatase, do not get panic. Just realize that all other parameters are normal, then it may be normal physiological rise in that particular pregnant zone. With regards to albumin, we know there are two things that is happening. So albumin globulin ratio will be a slightly altered. Normally, we have 1.5 to 1.7:1 ratio of albumin and globulin in non-pregnant state. But in pregnant state, it would lead to like 1.2:1. Even 1:1 would be a little fine because the molecular weight difference will be there with regards to the filtration of albumin and globulin. Only if that particular ratio goes down to 1, then we might have a little presumption or a prediction of that patient having hypertensive disorder of pregnancy. So albumin, because of physiological hemodilution as well as a little reduction in the protein synthesis, will be reduced as compared to the non-pregnant state. Bilirubin and the total and direct and indirect will be like a little not much changed, but bile acids, cholesterol, and triglycerides, because there are increase in steroid hormones, majorly estrogen and progesterone, there will be rise in first, second, and third trimester as compared to the non-pregnant state. But still, we are not worried because we are not having any other altered parameters, nor we are having any other problem with regards to any of the systems. So simply relying on investigations or trying to treat the investigations would be a huge fallacy. And that is why we need clinical correlation each and every time we are trying to investigate a female who is pregnant. When it comes to radiological findings, normally in pregnancy, the biliary will be normal. As we know, the progesterone will have a smooth muscle, relaxant impact. It will lead to cholestasis. And that is why the female who is having increasing propensity to developing gallstones, she might develop a little bit of gallstones on sonography finding. And that will increase volume as well as both the cases, the volume or the gallbladder volume will be raised on ultrasonography. When it comes to now, what would be something that we can call it as pathological? So the analysis with regards to liver disease or liver disorder point of view, we need to actually having proper workups, basic workup that we can have in form of history, general examination, clinical examination, and investigations. With regards to history, we need to have proper history of prior pregnancy as well as associated liver complications in previous pregnancy, IV drug use, any transfusion history, the term of pregnancy that she is right now having, along with the usage of oral contraceptives, how long she has been using it before this pregnancy, and from which age, and right now the age of the patient. With regards to clinical examination, we need to rule out following symptoms, that is nausea, vomiting, jaundice, general symptoms, pruritus, polyuria, dyspsia in absence of diabetes and abdominal pain. and then we would go ahead with laboratory and other investigations.
Dr. Munjal, would you wait for a second? Dr. Bharti Maheshwari has joined in, so we can just take her input and allow her to, go on with her work. Bharti ma'am, you have already been introduced. Would you like to say something? Bharti ma'am?
Yes, can you hear me?
Yes, ma'am. Yes, we called you before the program.
Sorry.
Yeah.
Yes.
So we have introduced you, ma'am. So if you would please go ahead.
Okay. Okay. So first of all,
Munjal, would you
congratulations.
stop sharing for a minute?
I'll do that, ma'am. Yeah. Done.
Yeah. So thank you, Dr. Munjal. So first of all, congratulations, Dr. Asha Jain, for organizing this wonderful program. And as we all know that liver disease in pregnancy, it is always challenging for all of us. And it has lots of issues like acute fatty liver of pregnancies, or if we talk about the HELLP syndrome, or we talk about the infection or hepatitis in pregnancy, and all are challenging. And as today we are going to have a very good lectures as well as panel. So this is all we have to understand, that we have to understand the detailed pathophysiology of liver disease and its impacts on the pregnancy as well as management. On the same times, we should use multidisciplinary approach, because most of the time, the timely management and timely intervention by experts, which is very much helpful for the patient as well as for good outcome. So again, thank you all societies, what Dr. Asha has joined for this program. And thank you very much for inviting me, Dr. Bharti Maheshwari from Meerut Obs and Gynae Society, as well as ICOG Governing Council member. And I request all of you, those who are joined and those who are associated with this webinar and their friends, that please support me for the coming 2025 year for FOXY, North Zone Vice President. Thank you. Thank you very much. Thank you, Dr. Asha Jain. Thank you very much.
Welcome, ma'am. Welcome. So thank you for being with us. And I can see you are very busy somewhere. So
yeah, I came and you have given me opportunity. I am very much obliged to you that I could meet
your
you
again for
gathering.
A talk, but we'll call you for a talk in the near future. Meanwhile, thank you so much for being here. And Munjal, if you would be kind enough to go on.
Thank you. Thank you. Thank you.
Thank you, Fatima. Thank you. Yes. Yeah, I think it is visible now. So now, just to simplify things, I have tried to keep this particular topic to a little simpler, in language. I have divided it into 3 zones. One is liver disease unique to pregnancy, or maybe because of pregnancy. The second one is unrelated to pregnancy, and third one is pre-existing before pregnancy. So if we go ahead with the first category, that is liver disease unique to pregnancy. Now, we all are aware of this table, right? IG is hyperemesis gravidarum, ICP is intrahepatic cholestasis of pregnancy, preeclampsia or HELLP syndrome, and acute fatty liver of pregnancy. Now, this 4 fall under that particular category where liver disease happens due to pregnancy. So, initial investigation or evaluation in which hyperemesis gravidarum can be diagnosed would show the workup that would have elevated ALT and AST, which is usually normal in pregnancy. And sure, no evidence of GI obstruction is there, because she would be having intractable vomiting at times, because we are having something which is not normal morning sickness, and upper GI scopy needs to be done in that particular case. While in case of intrahepatic cholestasis of pregnancy, there will also be elevated ALT, AST, exclusion of biliary diseases needs to be done, and diagnosis of concurrent chronic liver disease needs to be ruled out as well. In case of preeclampsia HELLP, we are pretty much aware and exposed to such cases where it will be elevation of ALT, AST along with low platelets, exclusion of underlying chronic liver disease and other causes of acute liver failure. Abdominal imaging needs to be done to assess vasculature and signs of portal hypertension, which might be associated finding. In case of acute fatty liver, there will be elevated ALT, AST. If evidence of acute liver failure is there, consider viral hepatitis, including herpes viruses, drug-induced liver injury, autoimmune hepatitis, Wilson's disease, vascular or ischemic changes in liver, and prognostic guidance can be obtained from physicians as well. So we know basic pathology in all 4 diseases. I'm not going in detail with regards to etiopathogenesis. Now, how would we manage during pregnancy the hyperemesis keratoderm? We know that usually that particular case would lead to the starvation ketosis because the female is not able to take anything orally in severe cases. So treatment needs to be done in form of injectable fluids, IV fluids, along with the injectable antiemetics, and safety data needs to be obtained as well. And use of PPIs with regards to reduction or treatment of acidity so that she can gradually start taking things orally. In case of intractable cholestasis of pregnancy, there will be bile acid monitoring. There will be also deoxycholic acid as well usage. We all are aware, and pruritus treatment needs to be done properly. Provision of alternative therapies in form of plasma exchange in severe cases can be done. In case of preeclampsia and HELP, hypertension needs to be managed properly in proper range, along with keeping all the parameters in normal range. If necessary, a termination of pregnancy needs to be done as well. In case of acute fatty liver of pregnancy, monitoring and treatment of liver complications, along with ruling out and managing encephalopathy, ascites, and renal failure needs to be done. Referral is very, very important with regards to 2 major points. One is direction of management, at the same time taking care of the litigation part, because it's not that being an obstetrician, we may not be able to manage it well, but when we have multidisciplinary approach, as Dr. Bharti Madam said, it would have a proper or optimal outcome with regards to mother as well as fetus or the newborn. In case of postpartum phase, in case of hyperemesis keratoderm, the evaluation of chronic liver disease needs to be done so that persistent pathology needs to be ruled out. In case of intractable cholestasis of pregnancy, evaluation of chronic liver disease in females with persistent liver taste abnormalities needs to be done, and further evaluation with physician can be done. In case of preeclampsia, we know that a recurrence of preeclampsia and HELP can be there. At the same time, nowadays, because we have the modality in form of MRI, the PRACE syndrome is there as well. And that is why we need neurophysician opinion as well. And in case of acute fatty liver of pregnancy, again, proper monitoring needs to be done in postpartum phase so that the care of fetus or the newborn is proper. At the same time, there won't be recurrence. So just again, a simple chart with regards to hyperemesis keratoderm and all the electrolyte imbalance that might happen, along with the etiology and the maternal and fetal complications and treatment. Now, such kind of simple chart can be kept in your OPD as well, because nowadays we deal with a lot of patients who might come after proper searching on Google. Again, we use word proper because we need to respect the research that they do, but at the same time we can simplify things for them, and that would have a positive impact on the advices that you are going to give. So dealing with that particular zone where we are having liver disorder due to pregnancy or related to pregnancy. This is just a simple chart of differential diagnosis. The mortality and morbidity would be a little high in all 4 of them, but then again, management would differ. One thing I would like to tell about acute fatty liver of pregnancy is there is one particular symptom, that is severe hypoglycemia. The RBS or the random sugar would be around 60 to 70 milligram per deciliter. And that would be a huge differentiating point. Differentiating it from other 3 disorders. So proper management, particular monitoring, proper diagnosis, and then, proper follow-up is very, very important in all 4 of them. And that would lead to a little more optimal outcome with regards to mother as well as newborn. This is again a little summary. Time of presentation in case of acute fatty liver of pregnancy, majorly it happens in late 2nd or 3rd trimester. And then all other diseases we are very much aware. Autoimmune, I'm not going into detail because it is a little more complicated. So we need to know the proper laboratory criteria to define or stamp particular disease. We need to know the proper monitoring and then follow up. Those diseases, the second category, which are unrelated to pregnancy, that is like viral hepatitis. Now, this is majorly infective kind of hepatitis. So immunoprophylaxis needs to be given if the baby to the newborn, if the mother is having acute hepatitis B infection. To mother, again, immunoglobulin and vaccination need to be given. Again, physician reference would be of great help before administration of both of them. Treatment for such acute infective hepatitis would have tenofovir, maybe at the start of 20 to 30 weeks of gestation, because we need to safeguard the baby within the uterus as well. And if the viral load is more, then tenofovir will have great impact and reduction in vertical transmission to the baby. So risk of vertical transmission in all hepatitis will be there, but with regards to hepatitis C, it will be minimal. And then cesarean section is not indicated just because the patient is having hepatitis. So routinely, vaginal route is preferred in case of infective hepatitis. One hepatitis which is detrimental is hepatitis E. Now, the maternal and fetal outcome, if the patient is having acute hepatitis E, is worse. Majorly in third trimester, maternal mortality can reach up to 30% and fetal mortality can reach up to 50%. And vertical transmission risk is very, very common. And that is why hepatitis E needs to be having proper monitoring, and the counseling part is very, very important because she can go into acute liver failure along with the derangement in coagulation cascade leading to DIC very, very quickly. And that is why the counseling part needs to be proper. Until the termination of pregnancy with optimal outcome of mother and newborn is not there, we must not take that guarantee zone for explanation to relatives that everything is normal. No, if she is in acute phase of hepatitis infection, that kind of guarantee must not be given to the patient and relatives. With regards to HSV2, basically it is genital infection. We know that, but then it has a huge impact on liver. Serum transaminophosphorases will be high, severely elevated, mimicking AFLP, but the jaundice will not be there. The diagnostic part from a clinical examination will be herpetic lesions in vulva and or cervix. Imaging would reveal multiple low-density areas of necrosis, and liver biopsy would show cow dry lesions, which are characteristic of HSV2. And treatment would have acyclovir. Again, in fulminant infection, the mortality part or probability will be high. The second part in unrelated pregnancy disease would be vascular liver disease, not majorly encountered or seen routinely, but then it has origin in form of increased estradiol, leading to increased procoagulant factors and reduction in anticoagulant factors, leading to more chances of thrombotic events, majorly portal vein thrombosis and Budd-Chiari syndrome. The third part in unrelated disease would be biliary tract disease. The cholestasis would be aggravated because the pregnancy again has more of progesterone, leading to cholestasis, and that could aggravate acute cholecystitis within 1 year of postpartum phase even. The treatment would be antibiotics and IV fluids, but if required, if she needs to undergo cholecystectomy, that can be managed after delivery if things are kept normal within normal range. Now, third category is pre-existing liver disease. If the patient is already cirrhotic and she gets pregnant, there will be worsening of jaundice. Evaluation and treatment of varices needs to be done majorly before pregnancy if the pregnancy is planned, and if not planned, second trimester can be a zone where she can be monitored for varices. Non-selective beta blockers or even banding of varices in severe cases can be there if the patient is showing signs of portal hypertension. Newborn might show bradycardia and hypoglycemia because if the patient is on beta blockers, the impact will be there on newborn as well. And in case of termination of pregnancy at full term, vaginal route is preferred as compared to cesarean section. These are the things not routinely encountered, but again, to complete the list I have mentioned. The second part is autoimmune hepatitis. Can happen in younger females majorly. High level of gamma globulins and ALT will be there. And the presentation might be asymptomatic or acute or chronic liver failure. Treatment can be in form of steroids or azathioprine, which is again category D drug. But if given in low dose, can have good control of the disease. But again, the risk on vertical transmission or damage to fetus can be minimized. And breastfeeding will be allowed in such cases. Third part is Wilson's disease. Honestly, I haven't seen a single case of Wilson's disease till 15 years of my experience as an obstetrician. But again, to complete the list or to have that theoretical or academic completion, I have mentioned this. The treatment is majorly in form of the chelating agents in form of D-penicillamine or zinc, and poor maternal and fetal outcome will be there in such case if untreated. And miscarriage, stillbirth, and prematurity will be common. Chelating agents are teratogenic, but zinc is now considered as the safest amongst all of them. Breastfeeding should be avoided if mother is on D-penicillamine, as it carries risk of goiter or hypothyroid goiter in newborn. So basically, I have tried to summarize liver disease along with other modalities in pregnancy. Just to complete, if the patient has undergone liver transplantation, pregnancy needs to be deferred at least 1 year. But then if she gets pregnant, the autoimmune or immunoprophylaxis or immunological medications need to be given by trying to balance the risk-benefit ratio. Renal dysfunction along with liver transplantation will have a very, very poor outcome, not only for fetus or newborn, but also for mother as well. And breastfeeding needs to be avoided if the patient is on immunosuppressant. So I think I have tried my best to cover a liver disease and pregnancy because we have a panel discussion on the same topic as well. I have tried to
Dr.
cover
Munjal,
major.
you have
Yeah,
taken
ma'am.
half your time. You've taken just half your time.
Okay, but I cut it
So
to this
I
many
would
slides.
really want you to go back to the first part
Yeah.
and the
Okay.
three major charts that you had, if you would just explain them out.
Okay, I'll do
Yeah.
so, ma'am. I'll do so.
Starting here, because, this is what we really need to understand. And I hope you
Sure.
don't mind.
I don't mind, ma'am. I don't mind. So basically, I was having a presumption of 15-20 minutes, and that is I skipped
No,
the initial
we kept
slides.
just one lecture. We kept
Okay.
just one lecture. So you have 40 minutes. You have
Okay.
another 20 to go.
Okay, ma'am. So we can have interaction as well because you and a lot of experts are there as well. So now coming back to the major chunk that we usually deal as an obstetrician, that is liver disorders due to pregnancy. As we now know, the hyperemesis gravidarum, intractable cholestasis of pregnancy, preeclampsia, and acute fatty liver of pregnancy. When it comes to hyperemesis gravidarum, in all four of them, liver enzymes are elevated. In hyperemesis gravidarum, we need to rule out that there are no other GI obstructive pathologies. As in, there is no small bowel obstruction, there is no duodenal obstruction, there is no other pathology which is leading to symptoms in form of intractable vomiting. So then only this particular term can be stamped, that is hyperemesis gravidarum. Intractable cholestasis of pregnancy, again, liver enzymes will be elevated. Exclude the biliary diseases. If she's having any pre-existing biliary diseases, we need to reconsider the diagnosis. And diagnosis of concurrent chronic liver disease needs to be ruled out as well. In case of preeclampsia and HELP, we know that what is preeclampsia and HELP. Nowadays, I think in ACOG and International Society of Hypertension, a study of hypertension in the pregnancy has come up with one classification, which is over and above the routine or usual classification we have. They have divided hypertension in majorly two categories. The one is hypertension before 20 weeks, and the other one is hypertension after 20 weeks. So if you have not gone through that particular classification, it is very, very useful and practical classification. So when it comes to preeclampsia of HELP, it is something where severe hypertension in pregnancy, we have complication in form of blood pressure not being controlled. At the same time, we have hepatic enzymatic defects. We have low platelet count. Again, there are a lot of classifications in use, majorly or practically. It can be classified in form of two or more criteria present, or just one criteria present out of all those criteria, three criteria. It can be also be classified on basis of platelet count. If the platelet count is between 1 to 1.5 lakhs, 50,000 to 1 lakhs, and less than 50,000. Again, it all depends on the symptoms as well as how grave the situation or hemodynamic status of the patient is. We need to exclude pre-existing chronic liver disease and other causes of acute liver failure. And sonography of abdomen would be of great help to rule out other pathologies and to stem the diagnosis of preeclampsia and HELP syndrome. When it comes to acute fatty liver of pregnancy, again, it is not that common, but again, it is not rare as well. Again, ALT and ST will be raised. If the evidence of acute liver failure is there, consider viral hepatitis, which might be pre-existing or just set in. Drug-induced liver injury, if she is on any kind of medication which might have detrimental impact on liver. Autoimmune hepatitis needs to be ruled out. Wilson's disease needs to be ruled out, and any vascular or systemic changes in liver needs to be ruled out. So these are the four pathologies basically majorly seen in obstetric cases. With regards to management, as we discussed, in hyperemesis gravidarum, treatment needs to be given in form of IV antiemetics and IV fluids. We need to properly take care that we are not having any kind of volume overload while having IV fluid infusion. Majorly, it would be around 80 to 100 ml per hour. At the same time, the focus needs to be on the renal output as well. We do not want to keep on giving fluid at such a rate that the renal system gets overwhelmed, and that is why the input output charting is very, very important and crucial with regards to managing any kind of volume derangements in pregnancy, because we know that there will be at least 50% more blood volume over and above non-pregnant state when patient reaches around 32 weeks of gestation. So those kind of patients will be having, the patient who are having volume derangements will be at higher risk of developing cardiac or renal complications if they are not able to manage the fluid properly. Because at some point of time, that left ventricular hypertrophy might give up. And then in such cases, we might see the myocardial hypokinesia as well. So even if the output is normal, even if the renal function is normal, the cardiac status needs to be taken care very, very well as well. And that is why if the patient is losing a lot of fluid, we need to keep in mind the fluid balance, input-output chart. At the same time, electrolytes are very, very important. Which fluids to be given is to be decided by the electrolyte investigations only. We cannot just simply keep on giving RL because it is physiological saline. We need to keep in mind which kind of isolate needs to be given, which kind of state she is in. Serum acetone, we are aware that is very, very important because we need to rule out ketoacidosis. If she is having ketoacidosis, again, the management would differ because the role of insulin and the dextrose would set in. And that is why all the knowledge we have needs to be implemented properly by proper monitoring. For postpartum case, as I discussed, evaluation of chronic liver disease in females with persistent liver taste abnormalities needs to be done. It's just like monitoring something after H mole. If the patient is having H mole, you have done your work by DNA and you will monitor your LCD. Same goes here as well. If the liver enzymes do not fall in normal category, we need to keep on monitoring and need to keep watch on those investigations. And then again, parallel physician reference is going to be there. But again, for next 6 weeks after the delivery or CS or termination of pregnancy, we need to keep an eye as well, because that particular patient will come to you because she has undergone treatment with you of that particular pregnancy. And that is why even for our knowledge, even for the faith that she has in us, we need to have that proper monitoring, even if she is being treated by physician for the liver disorder. When it comes to intractable cholestasis of pregnancy, bile acid monitoring is very, very important. Consider URSO, as I said, if serum bile acids are more. Recommendations of pruritus management needs to be done. Usually, patient in the normal physiological state as well would complain of pruritus. In that particular case, we have normal symptomatic management. But if the patient is having rise in bilirubin, if patient is having rise in liver enzymes, then such kind of agents would be of great help, which we usually do. We call it ancillary management. At the same time, dermatological reference would be a little help as well. So as again, it would be having a multidisciplinary approach with regards to managing that particular patient, because it is not like that we keep on telling her that cholestasis in pregnancy would have such symptom and it would go away once pregnancy is terminated. Because again, comfort zone and the good memory or the pregnancy memories is very, very important as well. We do not want that particular patient to suffer psychologically just because she keeps on having that pruritus and she keeps on scratching. We need a solution, however futile it may seem physiologically or pathologically. For postpartum phase, evaluation of that particular chronic liver disease in female needs to be done in form of this blood investigations of liver enzymes and consideration of genetic testing in cases where liver test is not coming down normal, even in postpartum phase, needs to be done. With regards to preeclampsia, monitoring of complications, fetal as well as maternal, needs to be done. Guidance of management of liver hematoma, if encountered in form of sonography, can be taken from surgical part as well. And consideration of liver transplantation in severe cases, but I haven't seen a single case, such a case where it is required. Most of the times, termination of pregnancy, in case the condition is not getting improved, would benefit patient. And then I think the rest of the things can be done along with holding hand with physician. With regards to postpartum, Evaluation of chronic liver disease in females with persistent liver taste abnormalities can be done. Again, followed up in just like the other two cases. In case of acute fatty liver of pregnancy, monitoring and treatment of liver complications need to be done. Encephalopathy is something which needs to be ruled out. As I said, MRI in majority of the cases of preeclampsia and eclampsia would show this posterior reversible encephalopathy syndrome. So when it comes to encephalopathy, usually what happens is we refer patient to physician and then neurophysician reference would be required. And usually after termination of pregnancy, patient would have improvement as well. So most of the times, neurophysician would have anemia monitored, and if things are normal, then nothing else is required other than conservative management and proper monitoring of neurological signs and normal physical, improvement that we might see after termination of pregnancy. In case of postpartum phase in AFLP, monitoring or worsening of symptoms need to be, monitored in early postpartum phase, and evaluation of chronic liver disease if the investigations or the liver enzymes are constantly on rising side. So all four diseases I have tried to cover. Again, if we go ahead with this particular picture, that is hyperemesis gravidarum, the symptoms will be in form of protracted nausea and vomiting. Onset is usually in first trimester because as we say that morning sickness or hyperemesis gravidarum is due to estrogen, progesterone, HCG, and all other hormones to which the body is now, exposed for the first time. So majorly in primary patients, we see that because they are not accustomed to that. The body is not accustomed to that. And at the same time, the intake of fluid or even the semi-solid particles is not possible for them. Weight loss is usually more than or equal to 5% of pre-pregnancy weight because, again, the intake is not there. Electrolyte imbalance is very, very common. Dehydration is common. Tylism, that is excessive salivation, will be there because the food is not getting in. At the same time, those altered taste sensation is creating problem for patients. Nausea may be severely debilitating because she keeps on throwing out even gastric acid at times. And that is why it is very, very important to treat patients in that particular zone. 20% of females would have symptoms throughout the pregnancy. So counseling is very, very important, not just pharmaceutical therapy, but counseling is very, very important. We need to tell them when to take food or fluid, what to be taken, what needs to be taken. At the same time, what needs to be done after intake of fluid or food particles. For example, if she wakes up and suddenly feels that morning sickness, she would have desire of, throwing it up. The counseling part, that is, we need to tell her that nausea is common. It's fine to have nausea, but then to make that attempt to feel relieved and then getting converted into vomiting is creating a problem. At the same time, we commonly advise tea and toast. We know that it is very, very useful to have, reduction or slight reduction in that particular feeling of nausea. She can have multiple small feed at a frequent interval so that the gastric emptying, which is now delayed, would have a little role so that the stomach gets emptied before the next meal. And then she would feel comfortable rather than feeling bloated and a little at discomfort. After ingestion of food, she can have a normal proper position or sitting position. And there has to be a little gap of at least 2 to 3 years between meal and lying down. That is, if she wants to sleep at 10 p.m., she can have her dinner at around 7 p.m. So these are basic advice we usually give, but at the same time, patient needs to be followed up with implementation of those advices as well. What kind of complications might happen with regards to maternal and fetal aspect? With regards to maternal aspect, she would have electrolyte disturbance, Wernicke's encephalopathy can happen. Thromboembolism can happen because, as I said, ketoacidosis might lead to a lot of derangement and even DIC might happen. GARD and esophagitis and gastritis will be there in initial phases. In fetal complications, the fetus might suffer from permanent neurocognitive abnormality due to nutritional deficit that the fetus might have. Growth restriction is common, and preterm birth can happen as well. So what is the etiology? As we said, genetic origin now has linked with that particular hyperemesis gravidarum. So there is increased risk in parents relatives, and the genes can be identified or sorted out if it keeps on happening in all the pregnancies. Endocrine and obstetric causes in form of hypoadrenalism, which is not very common. Hyperthyroidism can lead to that. As we know that hyperthyroidism is something which would mimic a lot of beta HCG impact on pregnancy. Diabetic neuropathy can also aggravate the condition. Polar or multipolar pregnancy, again, because the placenta or the bulk of placenta is more in both the cases, and that is why the HCG secretion will be very, very high. Again, mimicking a lot of hyperthyroid features. At the same time, aggravating what is hyperemesis gravidarum is. Gastrointestinal or other disorder might contribute to this particular case as well, which can be in form of peptic ulcer disease or H. pylori infection, gastrointestinal obstruction in form of small intestinal obstruction, or even duodenal obstruction might happen as well. And cerebral malignancy, again, very, very rare, just to complete the list. So what would be the initial treatment? Correction of electrolyte imbalance. IOUR charting needs to be maintained. Input in form of proper IV fluids, depending on the electrolyte imbalance. Titrate antibiotics. Basically, ondansetron would suffice. But at the same time, we can add on a lot of ancillary treatment if required, if the ondansetron cannot manage that particular case. We know that ondansetron is not safe for pregnancy, but again, it is not teratogenic, but at the same time, can be given and must be given at times when basic, doxylamine doesn't work. If severe, IV fluids and consider admission. So admission is required again for proper round-the-clock infusion of IV fluids, so that input-output charting needs to be maintained. Pulmonary edema needs to be ruled out constantly by monitoring of respiratory system. We cannot rely just on physicians to have RS examination. RS examination is part and parcel of obstetric examination, and we must not forget that part. So inspection, palpation, auscultation, these are basic things, not only for obstetric examination, but also for respiratory system examination as well. Nutritional support in form of assessment for vitamin replacement, thiamine, because we talked of Wernicke's encephalopathy, corticosteroids for refractory cases. Now, steroids are very, very tricky. As we know that in COVID, the major problem, started with the usage of steroids by general practitioners. So the same thing goes here. Steroids would have miraculous impact, but then at the same time, it is having detrimental side as well. So we need to keep in mind that usage of steroid is not something which would, help the patient in long run. So corticosteroids for refractory disease needs to be used, but at the same time, proper monitoring is very, very, very crucial. An enteral tube, that is like Rice tube, it needs to be. Why do we do that? Because we want stomach to be in deflated position, because gastric juice will keep on churning stomach, at the same time would keep on causing a lot of discomfort, and putting in Rice tube will have deflated stomach. So there are lesser chances of even aspiration into the respiratory system that might happen if the stomach is full, and at the same time patient is not able to be much oriented with regards to the reflux. What could be the mortality in hyperemesis gravidarum? So none, because most of the times we might terminate pregnancy if she is not able to tolerate. Perinatal mortality, it is not majorly concerned. Liver complications, jaundice is very, very rare. Other complications in form of electrolyte imbalance, if not treated, neurological, if again we talked not treated properly, thromboembolism might happen. And recurrence is very, very high in subsequent pregnancy. So counseling part is very, very crucial. We shouldn't discourage the patient or couple to have next pregnancies just because she is suffering from hyperemesis gravidarum in this pregnancy. Intractable cholestasis of pregnancy, maternal mortality is not so much, but in parental mortality zone, there might be slight increase and around 5% as compared to the routine, pregnant females. Liver complications, patient might keep on suffering with pruritus. Hemorrhage might happen if there is vitamin K deficiency. Some genetic variants are at increased risk of chronic liver failure as well. Other complications in form of preterm birth, which is very common whenever the patient, obstetric patient, finds any physical challenge. Preterm birth is always on chart. Meconium stain lichen might happen, and admission to neonatal unit because of the maternal impact as well as the prematurity might happen. The recurrence chances are very, very high. And that is why we discussed in history part, previous pregnancy or history of liver complications in previous pregnancy is very, very important. With regards to preeclampsia, maternal mortality is around 2 to 10%. Recurrence chance are high as well. Again, maternal mortality, when we talk is if she is not properly managed, then only. Baki, I think if she has not reached to a stage of DIC, we still have chance of saving mother. In case of perinatal mortality, it is again very, very high. Liver complications, ascites might happen because she is also having hypoproteinemia along with other complications in form of preeclampsia or HELP. She might have hematoma in liver, again needs conservative management. Nothing in form of active intervention needs to be done. In case of severe cases, she might have acute liver failure and liver rupture might happen as well, but I haven't seen a single case of liver rupture till now. Other complications in form of acute kidney injury, because AKI is very, very common. At times, what happens is, if such cases develop, for example, abruptio placentae, a lot of times, GPs or any person who is not much aware has a tendency to give diuretics. Now, in case of anuria with abruptio or even preeclampsia, if you give diuretics, the patient would develop acute tubular necrosis, and that would aggravate AKI, and then patient might go into irreversible renal failure. So please be sure that if you are not having any urine output, you can wait for 24 hours with proper fluid management. At the same time, proper monitoring of the blood pressure. And even after those 24 hours, you are not having urine output, then nephrologist would be of great help to take a decision of dialysis or any other management. But giving diuretics, that is majorly Lasix, in a patient who has just delivered or obstetric patient having anuria is very, very detrimental if you are not monitoring patient properly. So AKI is very, very amazing thing. If it happens, we might push the patient into irreversible renal failure. DIC might happen, sepsis might happen, abruptio placentae, eclampsia, pulmonary edema, again, fluid balance is very, very important, and postpartum hemorrhage can happen as well. Recurrence is going to be there. In acute fatty liver of pregnancy, maternal mortality is rare, but can reach up to 15%. Perinatal mortality, it is 5 to 20%. Stillbirth is very, very high in such cases. Liver complications, encephalopathy might happen, ascites, DIC, acute liver failure might happen. Other complications in form of pancreatitis, infections, and renal failure. Recurrence risk is very, very high if the effects of fatty acid oxidation persist. So acute fatty liver of pregnancy, though we encounter very rare, but it has similar features. We know that along with hemolytic uremic syndrome, TTP, that is thrombotic thrombocytopenic purpura, AFLP, all three of them share a lot of common features. And that is why we need to be very, very vigilant in diagnostic or stamping such kind of hematological disorders. And AFLP also falls under, that jaundice spectrum as well. So monitoring, diagnosis, investigations, this thing, if properly managed, can save patient as well as the fetus. So just to differentiate amongst all four of them, just a second. So with regards to AFLP, it is majorly seen in primigravida, in multiple pregnancy, and in underweight females. In case of preeclampsia, usually it happens in multifetal pregnancy. In case of ICP, it is common in South Asian individuals and multiple pregnancy. In case of acute viral hepatitis, there is no specific feature, but again, the history part is very, very important. When it comes to hepatitis E, we know that it is the oral intake of infective, just a pani puri, eating pani puri is very common. If she has altered taste, she might try it, and then usually such kind of history, unhygienic intake of food or fluid usually comes out. Autoimmune hepatitis, other autoimmune hepatitis, disorders are usually present as well. In drug-induced, we have history, usually none other than exposure to the drugs which might cause drug-induced liver injury. Time of presentation, basically with AFLP, it is in third trimester or late second trimester. In case of preeclampsia, usually in late second or third trimester. In ICP, usually third trimester. Acute viral hepatitis can happen at any point of time. Autoimmune, again, any trimester, and drug-induced any trimester, depending on the drug ingestion. Typical presenting symptoms in case of AFLP, nausea, vomiting, abdominal pain. 50% might have hypertension and proteinuria, and 20% of them might show HELP syndrome. ALT, as we noticed, ALT and ST both will be raised. Hyperbilirubinemia will be there, leukocytosis and hypoglycemia. As we talked, 60 to 70 milligram per deciliter RBS is very predominant feature of AFLP. In case of preeclampsia, features will be nausea, vomiting, headache, hypertension, proteinuria. ALT, ALP will be raised, but again, ALT will be less than 500. We go ahead with LDH as well. Thrombocytopenia will be there less than 1.5 lakhs. In case of ICP, pruritus, dark urine, post have jaundice or steatorrhea. In case of acute viral hepatitis, nausea, vomiting, abdominal pain, and fever will be there because there is infective pathology. In case of autoimmune, fatigue and nausea will be there. And in case of drug-induced, jaundice will be there. Laboratory features, we know that in case of AFLP, there will be marked hyperuricemia, elevated PTINR, DIC findings will be there. AKIs, investigations would reflect AKI and encephalopathy. In case of preeclampsia, hemolytic anemia might be there as well. Elevated LDH, hyperuricemia, and normal bilirubin will be found as well if the patient has not gone into MODS, that is multi-organ dysfunction syndrome. ICP, ALT will be raised, bile acid will be there, and normal bilirubin is usually seen. In case of viral hepatitis, we usually go ahead with IgG and IgM, which would diagnose acute or chronic hepatitis. In case of autoimmune, depending on autoimmune panel, we can have a varying range of results. In case of drug-induced, again, hyperbilirubinemia will be there along with elevated PT-INR. We know that PT and APTT will be reflective of intrinsic and extrinsic pathway. So the theory part needs to be implemented, then only it will be of use, or else all the knowledge will be zero. Key abdominal USG features in case of AFLP, there will be fatty infiltration and bright liver will be seen, and ascites will be there. You need a good radiologist to see such kind of features. In case of preeclampsia, ascites will be there, hepatic infarction or hematoma might be seen. In case of ICP, gallstones might be seen. In case of viral hepatitis, heterogeneous changes in liver echo texture will be seen. In case of autoimmune, heterogeneous non-specific changes will be seen. And in case of drug-induced, there will be heterogeneous non-specific changes as well. So I think it's just not a duty of an obstetrician to diagnose these conditions or cases. It's also something with regards to a support from radiologists, because at times we are very much concerned about the fetus as well. It's not just about mother. No doubt, mother being the major case, we focus on her, but it is our responsibility to have a proper, analysis of placenta, proper analysis of amniotic fluid, proper analysis of even Doppler, because most of the times in late second and third trimester, Doppler study will decide again whether to terminate the pregnancy or we have still some chances as well. So I think we have all the knowledge, we have all the multi-speciality with us, but just getting everything in sync, our knowledge, other specialty or support from them, at the same time, counseling, and the major factor, that is patient and relatives, who are of great, importance. They play a vital role. It is all about our explanation to them, which will help them to make the decision. But again, their own, their right to take that decision will be having great impact. And that is where the window shopping will stop. Most of the times what happens is, whatever we explain, they might not be able to digest, and they will waste very precious time in that particular, transport. Ultimately, they end up in whatever you have explained, but at the same time, they would waste very precious time by going here and there. And that is why we need to have a proper simplification in form of counseling. And then only we would justify ourselves or satisfy ourselves by doing the best and then giving the best to the patient and, having optimal outcome in form of mother as well as the newborn. So I think, ma'am, I have tried to cover the basic or obstetric cases. I'm really sorry for, finishing it in 15, 20 minutes. I'm really sorry for that. But I hope I tried to.
That's fine. That's fine.
Yeah.
Thank you for listening to me and, finally doing the whole thing.
I'm
Over
really
to
sorry.
you, Ruchi, ma'am.
Very crisp, concise, and comprehensive presentation, Dr. Munjal. You have put in everything together that we needed to know about it. Now, what we need to know is that the anatomic and physiological changes that accompany pregnancy, they alter the physical findings and the liver biochemistry. Yet, normal pregnancy does not significantly affect the liver metabolism and function. Because normally our pregnant patients are young patients, so they generally don't have a pre-existing liver disease. That's not a common this thing. And in about 3 to 5% of our pregnant patients, we will find some altered LFT. Very precisely, you had said that yes, there are certain diseases, certain liver diseases which are pregnancy specific, certain which are chronic pre-existing. One which as a group which I would like to add is iatrogenic, because I just encountered this and I would really like to share it with amongst us. She was an IVF twin pregnancy patient, and she was given so many progesterones, oral, IM, vaginal. When she came to me, her OTPTs were more than 1,000. And I'm talking of not just 1 month back incident. So I think injudicious use of drugs, just because she is an IVF patient and we try to pump her with everything, forgetting that, progesterones, they have a way of action. So one will do as good as the other will. So giving her 3 types, I don't think really helps in any way. We are rather creating this liver injury. And it was very difficult time to, and carry her through with all this, because she was vomiting, she had lost her appetite, and the liver enzymes were so scary for me as a doctor. Second thing I want to say is that as you were showing the chart of the liver function test in pregnancy, if we were seeing it a little intently, most of the liver enzymes, that's OTPT and our GGT, gamma glutamyl transferase, they actually fall in pregnancy. Why? Because of hemodilution. I mean, they fall almost 25% less than the normal compared to the non-pregnant state. But the alkaline phosphatase is the enzyme that rises. Now, why does that happen? That happens because the placenta is producing one enzyme, and that causes the rise in alkaline phosphatase. Similarly, when the patient has delivered and everything has come back to normal, the OTPT levels, they come down gradually. Again, why? Because they're not just liver specific. The smooth muscles, the breast, the whole exercise of labor, the trauma of delivery, breastfeeding, all these factors take time to have their effect on the liver enzymes coming back to normal. Whereas alkaline phosphatase, again, it will take around 2 weeks to come back to normal. Another important thing is when we are talking of ICP. ICP, I think, is very common. We are encountering it very commonly. Of course, acute fatty liver is a nightmare for whoever has gone through it, because the mortality is really very high. But ICP, I think we are seeing it right and left. We are seeing it very frequently. And ICP, now the bile acid levels can be measured, though it is a little expensive. But for when you have to monitor a patient, I think you have to look at the welfare of the patient and the fetus. So these costs really don't matter, because now you have these labs who can give you bile acids. So you do close monitoring of this patient. And why does ICP create problems? Now this bile acid, it increases gut motility, and so there is chance of passage of meconium, leading to complication in the fetus. And similarly, this bile acid sometimes causes cardiac arrhythmia and leads to sudden cardiac death. So ICP is also not a thing that we can ignore, though we are encountering it so commonly and we are using ursodeoxycholic acid. Yet it is one thing we have to be very careful about. We need close monitoring and when to deliver this patient. Acute fatty liver, of course, and why for acute fatty liver, for all liver diseases, I would say that yes, it's a teamwork nowadays, because sometimes when we see hepatitis B positive infection, now generally acute infection does not give rise to complications to the baby or the mother, but we know that we have to give the vaccination as well as the immunoglobulin to the baby. Chronic liver infections, hepatitis B infections are the ones which can, give trouble. So if you have to, in those cases, when you are considering tenofovir or you want to give an antiviral, you need to take the help of a hepatologist or a gastroenterologist. So it becomes a teamwork, so that the patient is assured that, well, she's on the right track and we are here as a team to save both the mother and the baby. So ICP especially, I mean, we need to be really very careful about it, because I think would really not be able to pinpoint exact reasons for it, but yes, it is definitely on the rise. We see it so very frequently. And for acute fatty liver, we know that they are that is a gene that is being incriminating, LCHAT gene. They are considering that that is the possible one that is responsible for this acute fatty liver of pregnancy. So we, well, it is a nightmare. So whoever, even help for that matter, is a nightmare. But because of all the, the gestosis score and our good antenatal checkups, I think preeclampsia is something that, we are able to control. I mean, it can be controlled, but like some mishappenings like AFLP are just, sometimes out of your hand.
Not in our hands.
Yes, sometimes you're just helpless. You just pray to God that the patient does well. As a teamwork, you are able to do it.
I think jaundice itself is very tricky. I mean,
Yes.
However efforts we make in diagnosis, even if we succeed in diagnosing, the
Right.
course of next few days
Yes.
is not at all in our hands.
Not
We can
at
just try to do our best and then pray. But jaundice is very, very pathetically, it's kind of chakravyu. We can
Yes.
get it, but I'm really not sure whether it's not at all in our hands at times.
Absolutely. Very nicely presented, Dr. Munjal.
Thank you so much, ma'am. Thank you. Thank you.
Thank you so much, Dr. Munjal, and thank you, Ruchi ma'am. Both of you excellent as usual. So
Thank you.
now I would like to start the panel. Dr. Munjal, Dr. Ruchi, would you stay behind?
Yes, I will.
Or you want to leave?
No, I will.
No, I'll be there. Yeah.
So both of you are the experts. When my panelists don't crash it, you will do it. Is my screen visible?
Yes, sir.
Yes, ma'am. It's visible.
Is the presentation visible?
Yes, ma'am. Yes, ma'am. You can make it full screen.
There.
Yes, ma'am.
Okay. So it's a liver diseases in pregnancy. As usual, we have beautiful Ganesh ji to take us over. And this is my Gurudev, always exhorting us that whatever you do, try to do it excellently. Always look for excellence. And here are my panelists. We have Dr. Meena Garg, Dr. Sanjita Pal, Dr. Jayneel Shah, Dr. Vedi Shah, Dr. Mohit Shah, and Dr. Ashish Verma. So Meena Garg ma'am is a graduate and PG with Roll of Honors from RH Medical College, Patiala. She's worked in the government sector for few years and then has settled in her own hospital in Garg Mission Hospital, Patiala. Past Secretary of Foxy Patiala, Life Member IFS, member of PCOS Society, and has a special interest in infertility, especially ovulation induction. We have Dr. Sanjita Pal, who's an MBBS MS from Pandit Jain Medical College, Raipur, is a credentialed IMS menopause practitioner. He has been trained in ultrasound and colposcopy, member of ROGS, RMS, ISOPAB, and SFS. She is working in the government sector in a 50-bedded hospital and is also practicing at Hope Health Hospital, Mana Camp. She has won the late Dr. Shobha Sharma Memorial Paper Gold Medal in Gynecon 2021 in our state conference and has published papers, also has first prize in online poster presentation on premature ovarian insufficiency in IMS. We have Dr. Jayneel Shah. He is an MBBS from NHL Municipality Medical College, MS from Sumandeep Vidyapeeth, DNB in 2021. So a really young gynecologist. He has a diploma in gynec endoscopy, fellowship reproductive endocrinology, fellowship in basic ultrasound, and presented and published 2 articles in BJOG. So we have Dr. Vedi Shah, who is the center head at Indira IVF, Ahmedabad. She is an MBBS from GMERS Medical College, MS from BJ Medical College, Ahmedabad, has a fellowship in gynec endoscopy, has an experience as senior residency in BJ Medical College, ex-assistant professor, Sheikh GS Medical College and Kaim Hospital, currently center head IVF. Dr. Mohit Shah, MS Gynae from BJMC Ahmedabad, FMAS, FRM, currently working as an assistant professor in obstetric gynec department of GCS Medical College for the last 3 years. Dr. Ashish Verma, Narendra Modi Medical College. He's an assistant professor at Dr. Munjal's Medical College only, Narendra Modi Medical College, Ahmedabad. Fellowship in Assisted Reproductive Techniques, Fellow in International College of Robotic Surgery, Diploma in Minimal Access Surgery, Fellowship in ART from Nagori Institute, and is interested in infertility and endocrinology. So welcome, respected panelists, and we now proceed to the questions. As usual, I have not allotted the questions to anyone. So we have heard all the theory about liver disorders. Now I want to ask you that there are physiological changes of pregnancy, and then there are the not so physiological changes. So what are the signs and symptoms that would distinguish liver disorders from a normal physiological change? Any of my panelists can take the question, please. Meena ma'am? Meena ma'am? I can't hear you.
Good evening, ma'am.
Yeah, please go ahead.
So, a very nice talks, and now I would, without wasting time, we have certain physiological changes in the pregnancy, and certain things increase, certain remain same, and certain parameters decrease. For example, the percolation profile is deranged in pregnancy.
Ma'am, what are the symptoms? Why will you get all this done? You know, the patient has come to you. What is different?
The patient,
Dr. Vedi, would you like to take this forward?
Yes, ma'am. Firstly, ma'am, thank you for inviting me for this topic. Now, if we are talking about the signs and symptoms of the liver disorders, so there are certain overlapping between the physiological changes, mainly because of the rise in the estrogen level, which is, as said by Dr. Munjal sir also, like the palmar erythema as well as the spider angioma. So apart from this, there would be fall in all other parameters, including the bilirubin. So if the patient is coming with us with the signs of the jaundice or yellowish discoloration, then that definitely points towards the liver disorder. Apart from that, there would be severe fall in there is a mild fall in the albumin level also, which might lead to a mild.
See, you are all talking about labs. Why will you get it done? My question is very simple. Why are you doing the labs? What is the patient presenting with?
The patient will come with.
Yes, so
She may have jaundice, but here we start. Don't we start with the first trimester? Dr. Ashish, I would like you to put in a word.
Madam, that is the early trimester. We have nausea, vomiting, but that is a morning sickness we commonly see on inspection and general complaints of the patient. But that if she is having more than a morning sickness, if she is having a whole day long nausea, vomiting, and epigastric pain or abdominal pain, and generalized weakness, malaise, and decreased food intake, and other GI symptoms, that we generally commonly see is in a normal liver problems in normal patients also, other than pregnancy also. If we see such kind of liver that associated with GI troubles, we can see that is all nausea, vomiting, abdominal pain. That is a very much commonly we encounter. So we should have should need to trick us to the liver, madam, that it is a commonly symptom.
Okay,
madam.
so if more than normal nausea, vomiting, you want to check.
Yeah.
Right?
Yeah.
So if it's leading towards hyperemesis, then only you will go ahead. Or if you clinically see jaundice, then you go ahead. Or you palpate liver tenderness. See, when a patient comes to you, you take a history, then you do a general examination. then only then you write investigations, don't you?
Yeah, always.
Yes,
Or you just get the patient and you write a whole list of
No, we
investigations.
always,
That
no,
doesn't
ma'am.
happen.
always
Can
ask.
I add something, Asha ma'am?
Yes, Dr. Ruchi.
See, because in pregnancy, the liver is generally not palpable. So if you are examining the patient and you find a palpable liver, then that should guide you that something is wrong. Because it is pushed upwards and posteriorly. So if you are able to palpate a liver in pregnancy, then you must suspect that something may be wrong. And again, the nausea and the vomiting, if it is so much so as to cause be so debilitating to the patient, not just because pregnancy patients most will come with nausea vomiting, we need to write an investigation for them, but it is so debilitating for the patient, and when you're examining the patient you can see that her physical condition is not conducive to the amount of vomiting she's having. That's when you will try to investigate.
So thank you for that. And now we proceed to the next. Okay, what is the most important diagnostic test that you're going to do? The complete liver profile, but where are you focusing?
Ma'am,
When will you think of alkaline and where will you think of bile salts? Yes, Dr. Mohit Shah?
No, I wanted to answer.
Yes, please go ahead.
Yeah, so the bile acids would be diagnostic in cases of ICP. So, normally we can see that in pregnancy, all other enzymes are not raised much. Only ALP is raised to 3 to 4 times. If we see any other enzymes, especially if we see serum bilirubin, apart from the bile acids, we can suspect that there is some problem with the liver. And to reach a diagnosis of ICP, we can see elevations in bile acids, like it can be if it is greater than 40, and in very severe cases, if it is greater than 100, then we can reach to a diagnosis of ICP. Uh, Also, we can use other modalities such as ultrasound, and also when we are diagnosing ICP, or even we have to, if we diagnose any other disorders which are underlying liver disorders, so to differentiate them, we can do other image, like we can use other imaging modalities.
Dr. Jayneel, would you like to add something?
Yes, ma'am. Ma'am, depending on the clinical symptoms that the patient has presented with, will decide if we want to get the bile acids done or not, because it is not available that widely everywhere. So if the patient complains primarily of pruritus, then I think we should be focusing more on the bile acids. Otherwise, in cases of normal nausea, vomiting, maybe jaundice, we may only restrict ourselves to doing the LFT as well as the alkaline phosphatase.
Okay. When would you want to do her hepatitis profile?
Fever.
Hepatitis profile, as a routine antenatal screening, also we get HPSAG and HCV is also nowadays included inside the screening profile. When we get the HIV, HPSAG, I think HCV is also
you
included
got that. Now the patient
Yes.
has come to you in the second trimester and she is vomiting, right?
Yes.
She has a little bit of jaundice. So
Correct.
means
if she
what
is,
are the indications? Yes, Sanjita. What are
ma'am,
the
if she is,
indications of getting hepatitis profile done?
ma'am, if she is from hepatitis E endemic area, then we should also go for hepatitis E viral marker, ma'am.
Generally, madam, weight loss.
Your mic is muted.
What is the indication of doing a hepatitis profile?
Madam, jaundice. Jaundice.
High risk factors.
Yes. And after we get elevated levels of the transaminases, then only we decided to go for the viral hepatitis.
Okay. You see a bilirubin of 8. Okay. A patient with a bilirubin of 8.
Yes.
What will you advise her?
We need to see the history, the past history of fever, nausea. can lead us to the diagnosis of hepatitis and help us may lead us to ordering the hepatitis panel.
We need to do
Okay,
the
so
viral markers as well.
Madam,
yeah.
this high bilirubin is mostly can be hemolysis of also. So we will go for LDH also, and other viral markers we will see other viral markers also. The hepatitis A we generally gets this high bilirubin. So hemolysis and hepatitis A is most commonly we see such high bilirubin, madam, mostly.
Okay, so if you have jaundice, if you have a palpable liver, you're going to go ahead and get a hepatitis profile done. If the patient is a case of hepatitis B or hepatitis C, is the disease affected by her pregnancy?
Yes, ma'am. Yes, ma'am. Because in pregnancy, there is immunosuppression. So viral load is more. Clinical course of hepatitis could change, and as GI symptoms are more in her.
Sanjita, put on your video, please.
Yes, ma'am.
Yeah,
Ma'am, as pregnancy is an immunosuppressive state, so viral load will be more, and clinical course of hepatitis could change. GI symptom will be more in her, and there is more chances of cirrhosis, esophageal varices, and moreover liver failure could be there.
Okay.
Especially in chronically infected women with hepatitis B and C.
Just now you heard Ruchi ma'am tell about, a patient getting a lot of progesterone and because of that getting liver injury. What other drugs have you seen in your patients which can cause liver injury and the patient has presented with that in pregnancy?
Alcohol.
Acetaminophen also. Acetaminophen.
And exactly. Paracetamol. A lot of paracetamol.
And many herbal medicines, herbal drugs, patients are just taking for
herbal drugs.
Nausea, vomiting.
Yeah. So especially those that contain minerals are the ones that cause liver and kidney injury. So we need to ask about that as well.
Also, ma'am, disulfiram. When for alcohol withdrawal, some people are taking disulfiram. That can also. And if it is history of OC pills before pre-existing, before the pregnancy, she's on OC pills for a long time. That also increases her hormone.
So when you say long time, what does it mean?
Maybe 1 year or more, ma'am.
1 year.
See, OCP people will be taking for years on end, 5 years, 6 years.
Those who are
these days
injury, then they are affected more. Others, those who are prone to liver disease because of other coexisting factors.
So now this is a patient, a common scenario in our OPDs. A woman in her late second trimester complains of intense pruritus, and this increases at night. So what is the single diagnostic criteria that would confirm that this is ICP?
Ma'am, first of all, she's in her late second trimester. Next is she had pruritus, that is intense pruritus, and we will do fasting serum bile acid level in her.
Non-fasting bile.
Sorry, ma'am, non-fasting serum bile acid in her, and
more than 10 micromoles per liter.
Yes,
indicate that she's a case of ICP.
There could be slight increase in serum bilirubin also, but it is always direct bilirubin. Alkaline phosphatase could be slightly increased also. And
what medicine are you going to give her? See, a patient comes to you, she comes for relief. So what medicine are you going to give her?
Ma'am, first of all, symptomatic treatment for pruritus, we can give her creams such as aqueous cream with menthol. Topical emollient can also be given. We can tell her that you should soak your itchy area with in cool and lukewarm water. And antihistaminics, which are safe in pregnancy, can also be prescribed. And
Just hold on, Dr. Sanjita, just 1 minute. Dr. Ruchi, you are there.
Yes.
Do you want to give antihistaminics for this?
Ursodeolic acid, ma'am, first of drug choice.
Ma'am, first is that you have to give simple treatment to the patient. First
That
is
Sanjita has
counseling.
described.
Yes,
Yeah.
you give her counseling, you tell her this is your, you explain why it is happening to her. She is to wear cool, comfortable cotton clothes, keep her body well hydrated, calamine lotion application. And when all that fails, then we go on to ursodeolic acid. If the enzyme is worsening, then we go to that. And I don't prescribe antihistaminics right away. If the patient is very much disturbed, it is disturbing her sleep at night, and or if I have just started with her ursodeolic acid, which will take some time to act, in those cases, for a very short period of time, I would give antihistaminics, not for a long period.
So means how shorter time and which antihistaminic?
Till the ursodeolic acid is taking over the effect.
Means
And
3 days, 5 days, 10 days, how many? Sanjita?
Ma'am, I'm sorry, ma'am.
I'd like to start them right away, not waste her time, because
No, ma'am. For how many days would you give and which drug would you give?
I would like to give her UDCA.
No, you've given UDCA, but antihistamic, which one do you want to give?
Cholestyramine is fine, ma'am. I would like to give a cholestyramine. Promethazine can be given 25
Promethazine or cetirizine or promethazine can be given for 5 days.
Levocetirizine can.
Levocetirizine. What about your experience with that Allegra or Bilastine?
Allegra is good, ma'am. Allegra can be given, very effective.
How many days? 3 days, 5 days, 10 days, how many days?
5 days.
Till her symptoms subside, once the UDCA will take over, her symptoms will decrease and then we can stop.
5 to 7 days. Yeah, 5 to 7 days.
5 days. 5 days is
5 to 7 days. That's it. 5 to 7 days.
Yes, yes.
So you have done her local treatment. You have given her ursodeoxycholic acid. What is the dose that you want to give of USD?
10 to 15 milligrams per kg body weight, ma'am.
No, ma'am. You have a 300 milligram tablet. You have a 150 milligram tablet. So how much do you want to give?
We start with, depending upon the OTPT levels. OTPT levels, if the levels, we can start with 300 BD, 150 BD. Maximum is up to 2000 milligrams per day, not more than 2000 per day. So generally the symptoms.
In your practice, what are you giving? Dr. Mohit?
I generally.
Yeah. So we are giving ursodeoxycholic acid 300 milligram once a day.
You are giving it once a day.
Once a day, 300 milligram.
Meena ma'am, आप कितनी बार दे रहे हैं?
Just recently, 2 days before only, I had a patient. She's conceived PCO patient with difficulty, 10 years married, and then in the first trimester, her OTPT is 150.
What is the dose you are giving?
Then I started, depending upon that, 300 BD.
300 BD.
You are giving 300 BD.
And after that,
Dr. Vedi?
She's
300 OD, ma'am.
Sanjita?
Ma'am, 300 mg BD, ma'am.
Ashish?
Madam, we start with 300 OD. We follow the patient.
Yes.
We see if she is having much more, then we can shift to BD also. And if she is comfortable with OD, she can keep OD also. We follow her for 3 days, madam, for that.
And now I have put her on one tablet 300, one 150 in the afternoon, and one 300 at night, because the levels are still high. They are more than 100.
Dr. Jayneel?
Ma'am, we can start off with twice a day, maybe even increase it up to thrice a day depending on the requirement, because the body day, according to the body weight, the dose requirement is already a lot more. So I think twice a day should be okay to start with. If it is not controlled, we can even shift to thrice a day, 300 milligram.
Okay.
And it takes a certain
practice,
period of
I
time.
give it 3 times a day because most of my patients are like 80 kg plus.
Exactly.
So I usually
Depending on the
start
body
with,
weight, the requirement is more.
yeah, so I usually start with 300 TID. And then once she is controlled, I would taper it a bit. But I start with a higher dose. Means that's just me. Dr. Ruchi, would you have anything to say on that?
Since the dose range is 10 to 20 milligram per kg per day, and an average female at least 70 kg,
60 to 70
I think
kg
that's
we
an
have to
average we
consider.
should have. So if you multiply it by say 10 also, that is 700. So at least 300 milligram BD to start with. And if it does patient is not responding, then I would increase it to 300 milligram TDS. But with all the accessory other local treatments that we are giving the patient, and I wouldn't taper it, madam, because this will not go till she delivers.
Yes.
So
I
I
agree,
don't.
ma'am. But
Yeah.
like, initially jada deke, like you said, na, 10 to 20 milligram per kg body weight. So I would prefer to start with 20 and come down to 10.
Exactly.
We
Once steady state
start on
concentrations are achieved, then we can reduce it. Also, the cost of the medicine is also very high.
Very,
So,
very high.
yes,
Very
so
high.
that is what we also have to assess, that patient should not think that we are prescribing very high costly medicines.
Now with, we get cheaper versions are there, good quality, but initially it was only Udiliv, it was very expensive. Now we get in good range. Other drugs companies have started marketing it with lesser price, much lesser, 50%.
Right.
Now, one more thing I want to ask you. When do you want to deliver this patient? She is the second trimester, but supposing you have carried her to 34 weeks and there is not much abatement in her symptoms and her bile acids still are above the 80 range. They are more than 80. Now, when do you want to deliver her?
Depend if the bile acids are high and if it's not coming down, especially if they are over 100, then I would if she has crossed 34 weeks, I would plan her delivery after her steroid coverage is over. And if it is less than 80 but still greater than 40, I would wait up to 38 weeks for delivering
No,
her.
she is above 80 still. She is still above 80. So when
Then
do
I
you
would
consider delivering
terminate
her?
the 36 weeks, or if the symptoms are not abating, then after the coverage of metronidazole, I would deliver her after 34 weeks.
Does the baby have any say in that? Do you want to do fetal Dopplers?
Fetal Dopplers
is
CTG has a role.
Only CTG, no Dopplers?
Ultrasound and CTG, ma'am. Biophysical scores are non-stress test.
What is your opinion about the Dopplers here?
What I have read,
Are you going to do Dopplers or not? Because she
it is
has
for
liver
the
disease. And
it
what
is for the
happens
mother.
in liver disease?
Yes, ma'am. Because fetal asphyxia could be there in this baby. So we also should go for a bi-weekly NST and fetal Doppler.
Okay. Fetal
Ma'am, there is
Doppler,
a
that's
risk
what I'm
of
saying.
there is a risk of sudden fetal demise in such cases. So fetal Doppler should be done routinely monitoring, but it is not to predict the sudden fetal demise.
Okay, so how will you decide when you're going to deliver her? What
Ma'am,
is your
we would also simultaneously
trigger? What is your trigger?
we would also be simultaneously monitoring the SGBT and SGOT. If the liver enzymes are also simultaneously elevated, then we should go for the delivery urgently.
Also, ma'am, fetal moments are very important. We should ask her about the fetal moments.
Yes.
If they are less than 6 per 2 hours, then also or less than 20 per 1 day, that is also very commonly useful.
Generally, the gastrointestinal people suggest that you should deliver the patient that she will be recover. So they are not advising to more than 36 weeks.
36.
Okay. So
yes.
That is for sure that we take out the baby at 36 weeks. Okay.
But if the symptoms are worsening before that, then I think we may consider an early delivery than 36 weeks as well.
Ma'am, if there's unremitting maternal pruritus and there's prior history of 36 week due to ICP or any pre-existing acute hepatic disease or liver condition is worsening, then we can go for termination, ma'am.
Continuously rising SGOPT and increasing bilirubin, these are the signs actually to deliver
Okay.
it.
Okay.
Maternal,
So
always
now,
maternal we have to assess first. Mother is first, then baby always.
so mother is sort of static, right? She's not worsening. Then what will be your trigger? And you said that we don't cross 36 weeks.
Ma'am, if bile acid level is more than 100 micromole per liter with elevated serum bilirubin at 36 week, 36 week gestation, we should terminate her, ma'am.
Okay. Now you have delivered her. What are your postpartum considerations? How are you going to follow her up postpartum? When are you going to do her next test? And how are you going to follow her up?
Ma'am, postpartum pruritus generally disappear in few days following delivery. Bile acid also normalize. And ICP is
How
not
many
a
days? How many days?
Might take 2 weeks, ma'am. It might take.
That is
3
what Dr.
weeks.
Munjal said. Couple
2
of
weeks.
weeks is what it takes for them to come down to normal. So you would repeat the test after 2 weeks,
2
right?
weeks.
Oh, yes, ma'am.
And if it is still not normal, then when would you repeat it, Dr. Mohit?
We can do it every 2 weekly. So then after 1 month. First 2 weeks, then after 1 month. We can repeat it 2 weekly.
Also,
If not,
we can
if
look
not,
at other causes which might be pre-existing, like any pre-existing liver disease, which
other
we might have missed earlier, and
We
which
can
is
go for
not
other
other
modalities.
causes.
Yeah, once
We
the
can go for
baby is not in, we are not worried. Small
we can go for
stones can be
other
there.
modalities.
Yeah, gallstones can be missed.
Gallstones.
Yeah. So we are done with the first case. Ruchi ma'am, at the end, would you like to add something before we proceed to the
The
second?
levels are not resolving, then we must keep in mind some other causes of this intrahepatic cholestasis. So there, that is where a hepatologist or a gastroenterologist opinion is very important. We must think of something else other than just ICP.
Okay. Okay. So now we proceed to the second case. This is an acute fatty liver of pregnancy. Third trimester, nausea, malaise, and jaundice. So how would you make the diagnosis of AFLP? What are the diagnostic features?
There are three main diagnostic features. One of them, most important, is hypoglycemia in these patients, along with the other things. And then they have leukocytosis because of inflammation. And then, of course, the enzymes are raised. And then there is no other cause, like hypertension is not there, proteinuria is not there. So these things.
Okay.
And
so, Dr. Ashish,
Yeah, madam.
what are the urgent tests that you're going to do?
Madam, complete liver profile and electrolytes are the and viral markers to rule out it is a
Random blood sugar. Blood sugar
Ma'am,
also.
CBC for
Blood sugar.
leukocytosis, ammonia level, ma'am, prothrombin time, APTT, ma'am. Also.
Okay.
As well as serum creatinine should be done.
Yes, ma'am. RFT should be done, ma'am. Because we had one criteria, Swansea criteria for the diagnosis of AFLP. With 6 or more, if 6 or more criteria is present with absence of other cause, we can diagnose it as AFLP, ma'am.
Okay. Dr. Vedi, ma'am,
Yes.
you have diagnosed that it is AFLP. Do you want a confirmation by ultrasound? And what will you find by ultrasound or an MRI?
So, ma'am, in the case of acute fatty liver of pregnancy, when we do go for putting a probe on the abdomen, we see typically macrovesicular changes in the liver area, where you will be seeing the radiolucent area on the liver.
right liver.
हेलो मीना मैम
Yes.
आप म्यूट हो गए हैं मीना मैम आप म्यूट हो गए हैं
Yes, ma'am. Apart from that, there might also be signs of we need to rule out that ascites is present or not in such cases.
Yes. So
And
you would have to
bright
see
liver.
ascites.
Hmm.
Yes, ma'am?
A bright liver, like microvascular fatty infiltration of the liver, and a bright liver in general in AFLP.
Okay. So now how are you going to manage this case? You are unlucky enough to get it. How are you going to
So
manage it?
we can manage it according to the clinical condition of the patient. Usually, the treatment of AFLP is delivery of the baby. Like it will only resolve after the baby is delivered, and it has the propensity to cause severe morbidity. Like it can lead to acute fulminant liver failure. So we need to manage, and we need to plan the termination of the pregnancy if it is confirmed, and if the patient is worsening. Like we need to assess the baby and its maturity, and need to terminate it as soon as possible after giving her proper steroid coverage, depending on the maturity.
Dr. Jayneel, will you be considering the baby and your neonatologist and
Yes.
neonatal ICU before you terminate, or you would terminate on the baby?
No, ma'am. I think for the maternal outcome, yes, termination of the delivery is important. And for that, the maturity of the fetus, baby also plays an important role. So a combined discussion should be taken between the gynae, the pediatrician, the neonatologist, and the patient, and their affordability as well. If they can afford the NICU care, that they'll undertake. But for the sake of better maternal outcome, they should be, more inclined towards delivery of the baby.
Okay. So you want the basic thing is to deliver the baby.
Yes.
Ma'am, after
Dr.
delivery
Vedi?
for
But we have to
hypoglycemia,
be
baby
certain
should
of
be
the
monitored.
diagnosis that we should have ruled out all other causes of hepatitis or liver disease, basically.
Okay. Dr.
After
Vedi, you want to say something here?
Ma'am, it depends on the gestational age of the patient, and anyways, the baby is at risk of even the fetal demise. So it is better to deliver urgently. And also we need to monitor the maternal condition. If it is worsening, there are certain parameters, like there is worsening of the hemolysis, or there is DIC which sets in, then, or there is worsening of the urine output. Then these
We
are the
actually
conditions.
don't want to wait for that. We really don't want to wait for that. We would rather prevent that. So, Sanjita, would you like to add something? And then last word from Dr. Ashish.
Dr.
You're
Asha, I
muted,
want to ask
Sanjita.
a question.
Go ahead, ma'am.
How will we deliver, vaginal or cesarean?
Ma'am, vaginal delivery.
Mode of delivery.
preferred.
That is what I was coming to next. If we are planning a delivery that early, like maybe the patient could be at 31 weeks, 32 weeks, the patient is not ready for a vaginal delivery, then I think what we do usually later on after 38 weeks of gestation is we do stretching and stripping of the cervix or some stimulation. So if we are even suspecting a little bit of AFLP, I think we should be pro towards a vaginal delivery because that gives a better prognosis. As the blood coagulation profile is also altered of these patients, and vaginal delivery is preferred. So the patient, we have to take a prompt action that we are going to try and deliver vaginally, but if the cervix is very resistant and we're not getting results, then we may even go for a cesarean section. But given that all blood transfusion facilities have all the blood products are ready.
Ruchi ma'am, did you get your answer?
What I would say is that, as you said, that we have not taken the patient to the level of coagulopathy.
Yes,
we have a patient, we have diagnosed her as AFLP. As of now, her coagulation profile is within limits.
Ma'am, that is why I was coming to the fourth question. That what are the indicators for delivery? When will you decide that now I'm going to deliver her? You don't want her to get into DIC and then deliver, right? Or liver failure or liver rupture. You're not waiting for that. So what are your triggers when you're going to plan delivery?
Ma'am, in my opinion, if the baby's weight is more than 2 kg, if the maturity is more than 34 weeks, and if we can plan a vaginal delivery safely in the next 48 hours, I think we should go for a delivery in such a patient.
Okay.
I mean,
And we
EFL
can avoid an NICU
or
admission as well, and we get a better maternal and fetal outcome both.
with
Actually, you
steroids
have not
and
answered my question. Dr. Ashish, I'll come to you.
yeah, ma'am.
What is your trigger of delivery? When are you going to say that now I want this baby out? What is your trigger?
Madam,
Maternal,
Ashish, then
maternal.
Meena, then Dr. Meena, then Sanjita. Okay?
yeah,
Yes, Ashish.
yeah. Madam, actually, nowadays, with the advancement of IVF, no, so that's why the NICU are very well established. Before also they were. So 30 weeks and 1.5 kg more than baby weight with steroid coverage, there are 90% the baby survival rate. So any patients of acute fatty liver of pregnancy and with jaundice or without jaundice also, if the uric acid is rising, she is getting a low sugar and signs and symptoms of acute fatty liver, after 30 weeks with steroid coverage 1.5 kg or 1.6 kg, I think we can't wait for more than 31 week, 32 weeks, ma'am.
Okay.
No, I think
Meena,
the
ma'am?
trigger would be deranged liver enzymes.
Fortunately, patients come a little
Dr.
late.
Mohit, I'll come to you. I'll come to you. Yes, Dr.
Oh,
Meena.
Sorry.
Fortunately, we get these patients a little later, in the later time, like maybe they're in 32 weeks, 33 weeks, so we are very safe. So
We can deliver.
the TBA, the trigger would be TBA. Total bile acids up to 40, it's moderate. 40 to 9900, it is severe, and more than 90, it is very, very severe. So if it is, we would not like to go to very severe and go into coagulopathy and then to deliver.
Madam, 32 weeks steroid and we should deliver.
Yes, yes.
Okay. So, Sanjita, I come to you and then I come to Dr. Mohit.
Ma'am, delivery should be within 48 hours of diagnosis, and if ammonia level is more, then patient could go into maternal hepatic encephalopathy. It can lead to hepatorenal syndrome, DIC and MODS. So if ammonia level, uric acid level, it is increased, then we should go for timely delivery at 32 week with Maxelf coverage and steroid coverage, ma'am.
Okay. Okay. Yes, Dr. Mohit.
Yeah, so I was saying that mother's condition is critical here. Like if her INR or liver panel is deteriorating, INR, if she is going into coagulopathy, if we can diagnose by the liver function tests or INR, then can take the decision of termination. But it is purely based on the mother, because for us the more important is mother in this case, because AFLP is slightly a severe condition. So
see,
even
Dr.
for the
Munjal said 15% maternal mortality, 50% perinatal mortality. That was the figures he gave. So 15% is really high, I think.
Yes. So I feel we have to take care of the mother first and then think of the baby. In cases of AFLP, ICP is commoner. ICP, we can think about the baby also. AFLP more, I think we should think of the mother.
Yes. So you had a patient of AFLP, she delivered and she recovered. But what are the long-term implications? Supposing you see her after a couple of years, what do you expect her to have?
Can have a chronic, can go into chronic liver disease, or if she might have had any deteriorating event in this pregnancy which might have been missed, she can go into chronic liver or chronic kidney disease.
Dr. Vedi?
Ma'am, same.
Same. No addition here?
One addition, ma'am, I'd like to say, because it is a deficiency of certain long chain agents. So when the baby, on the baby, we should do long chain 3 hydroxy coenzyme dehydrogenase test to the baby, because if it can be carried on to the baby also, this disease. So we should do that test on the baby after delivery.
Sanjita?
Ma'am, hepatic failure and hepatic failure and risk of hepatocellular carcinoma, ma'am.
Cirrhosis.
Okay.
Yeah.
So we come to the last, that is Ruchi ma'am, before we go to the third case. Your final comment.
When we are talking of acute fatty liver of pregnancy, as we said, it generally presents in the third trimester. So mother is the primary concern. As soon as we have stabilized the patient, we should deliver her, not waiting for any time, 34, 36, 30, nothing. You stabilize the patient and you deliver. That is the dictum for acute fatty liver, because there has been no report which says that continuation of pregnancy is going to improve the condition. So why are we waiting? For what are we waiting? We are just going to add to the maternal mortality by waiting. The perinatal mortality is already high. So as
then you would do a cesarean?
I will deliver her, whether it's vaginal or I would assess her if she's favorable cervix. I mean, I would induce and deliver her. My decision for delivery would be made once I have stabilized her. I'm not going to wait. I'm not going to wait for anything. No weeks waiting for her.
So you have induced her. How many hours are you going to wait?
As such, not a question of hours. I'm going to monitor her hypoglycemia. I have to monitor, see her electrolytes. I have to see how her labor is progressing, and my decision will be based from time to time examination of the patient. As such, I cannot put a label that I will give her 2 hours.
Put in Serviprem, or you've put in a Foley's catheter. So how long are you going to wait to see whether she's going to progress or not? 6 hours?
Yes, ma'am. I would like to wait 6 hours. 5 to 6 hours.
Okay. So now we come to the third case, and this is hepatitis E. This is the first trimester. The lady has come from an hepatitis E endemic area. So how are you going to confirm that what she has is hepatitis E?
Serum marker, serum IgM marker.
Ma'am, there could be 2 type of marker or diagnostic criteria. First is direct, that is direct viral detection in blood or stool by direct virus itself, its nucleic acid or its protein, and indirect by antibodies like IgM, which is indicating recent, IgG, which is indicating past infection.
So basically, you would do a PCR or you would do an antibody.
Antibodies.
Either of the 2 varieties.
Yes.
Okay. So now you have that she is hepatitis E. What is the treatment that you're going to provide, Dr. Mohit?
So she needs to be assessed clinically. Usually, hepatitis E is associated with diarrhea, and she'll have fluid loss. So we'll give her fluid support, and then assess her hepatitis. If she has other symptoms like fever or nausea, vomiting, we would like to treat that, and also we would like to give her fluids according to her blood pressure. If she has severe hypotension or dehydration, we would like to do proper fluid management before thinking
Dr.
of any
Jayneel,
antiviral.
Is there any role of antivirals here?
No, ma'am. I think more of the treatment is based on the supportive treatment that you give. But I think immunoglobulins can be given if the severity is very high. If it is not controlled by the routine supportive measures, then we may consider other treatment.
So
but
how are you going to?
There is no other specific
how are you
treatment
going
that we
to
can
monitor the fetus and mother?
Ma'am, for the
How
maternal.
frequently?
Yes, ma'am. Firstly, initially, we need to take the baseline vitals of the mother and also note down the fetal heart rate and the Doppler depending upon her gestational age. And later on, we need to
This is
frequently.
a first trimester case. This
Yes,
is a
okay,
first
for the first.
trimester case.
So baseline, we need
how
to
are you
assess
going
that
to
there is.
monitor the fetus and the baby?
Yes,
and
we
the
need
mother?
to. Yes, we need to note down the fetal heart rate on the baseline once she's admitted. And then later on, we need to monitor the mother's symptoms, whether she's improving or not improving. If she's improving, then once she's stabilized, we can again reassess the feet. Ma'am, I don't know about, I'm not sure about the fetal monitoring, but yes, mother needs to be monitored regularly.
Okay. Anybody wants to say anything about fetal monitoring?
I think
How are you going to follow this baby?
Without worrying about the fetal outcome, I think we should only be treating the mother. We should try to prevent any kind of hypotension that can be detrimental to the mother as well as the fetus. So I think only if you monitor the mother, that should be good enough. I think we should take a consent for a poor neonatal fetal outcome. And I think we can proceed with the treatment.
Dr. Ashish, the patient is asking you that I have had this in my first trimester. So will it have an effect on the baby, or should I have an abortion? Or should I continue? What will be your advice
we
here?
generally don't advise for abortion, and maybe there are because nowadays there are so many modalities to rule out many more things for the fetal early anti scans, second trimester NIPTs and anomaly scans. So we don't advise for HEV that to abort, and we say her that we will monitor. And there is no definite criteria that the babies will be there will be maybe a vertical transmission for this. So we don't advise for abortion, madam. And for monitoring also, bi-weekly ultrasound and fetal health monitoring is more than enough for a fetal monitoring, madam.
Okay. Now, this patient, didn't go alone. If there are other patients who come to you who are in the first trimester and they are going to those endemic areas, what is your advice? How are they going to avoid hepatitis E?
Ma'am, first
What
of
will
all,
you tell them?
Ma'am, first of all, we should tell her to practice good hand hygiene. We will tell her to drink safe water. We tell her to eat properly cooked food, avoid raw undercooked meat, and not adding ice cubes to water. And we tell her to avoid unpeeled fruits and vegetables, ma'am.
That is the trick that you have said. Unpeeled fruits means what? If somebody has peeled them and washed them in dirty water, what then?
No, ma'am.
Better to have fruit, cut it yourself.
Okay.
Have the fruit ready and,
yes, ma'am.
Wash and cut it yourself. Don't leave it in somebody else's hands.
Yes, ma'am.
So basically nothing uncooked goes into your mouth.
Yes, ma'am.
Simple. That is the one base thing that we can say. And is there any risk of vertical transmission? Do we have anything that we can give to the baby, provided this has gone to the last trimester?
Risk of vertical transmission is of course there, ma'am. But then there is
it there with hepatitis E?
Yes.
Yes.
Depends upon the viral load.
Depends on the viral load, but it's more there with hepatitis C than E. So E, first trimester she gets it, most of the time it's just gone. So this is basically any patient coming with diarrhea and vomiting, you have to remember that you have to test if she's coming from an endemic area, or even if in your own area that you're not getting clean water for some, like in our area also in the monsoons in the beginning, there's an endemic of hepatitis E and hepatitis A everywhere. Presenting as diarrhea vomiting.
Yes, ma'am.
So we need to be aware of that. And now we go to the next case. This is a patient of hyperemesis gravidorum. Right? She has severe nausea and vomiting in early pregnancy and her LFT is abnormal. Now, how are you going to differentiate whether she had liver disease and then is having hyperemesis, or she has hyperemesis and that has caused the liver disease? How will you differentiate?
First of all, history is important, ma'am. We'll take a detailed history on if she gives history of liver disease earlier or in the previous pregnancy, what was her liver status like. If it was normal, then we consider it more of hyperemesis induced liver injury rather than liver involvement on its own.
Ashish?
Ma'am, if she's pregnant, we can ask her that if she's in first trimester, then hyperemesis would be since from beginning, because the body will have that symptoms in beginning. And if she's saying that previously I was normal, but since 10 days it aggravates, then you think that it is might be some of the other cause. Previously, she is having since first of all, because any hyperemesis would be because of pregnancy. But till she become pregnant, there would be an emesis, ma'am. So you can ask
Dr.
her that.
Mohit?
I would also go for detailed history. Like I would look for factors which are which cause hyperemesis gravidum, like sometimes in first pregnancy or prior history of hyperemesis is there. Then I would start suspecting it that there is a hyperemesis. I would ask history of prior liver disease. I would also ask some history of medications or drugs she might be taking, which can cause disease, liver disease. Also, I would ask about travel history, like there, like some travel which can cause infective etiology of hepatitis. I would rule out other causes of hepatitis and liver disease. Then, by rule of exception, I would go with hyperemesis gravidum.
Okay, so now she is vomiting. She has intractable vomiting. So you have tried, ondansetron. It isn't really working. So what, Dr. Munjal said, upgrade your antiemetic. What else can you give her?
You can try a combination.
Ma'am,
What
suppose
combination? What combination?
Dicyclamine and
Doxylamine.
doxylamine and pyridoxine.
And ma'am, thiamine is very important. Thiamine, 100 milligrams of thiamine orally or parenterally.
For
Vitamin
very
C1
severe patient, promethazine is very good antiemetic. And again, if we go higher than Dexona, it relieves that thing.
Hydrocortisone.
We have newer drugs in the form of rifaximin, 300 to 500 milligrams per day. And then we have another one like iron resin exchange drugs like cholestyramine. And these are the newer drugs which are considered. There's a new drug by UK by the name of XENOC, Zenoc, which is available in UK, not in India now. So these
So
new
what
drugs
I'm
can-
asking about you, let's not talk theory in the panel. What is available with you right now? Your
I think-
patient is vomiting. She has not responded to ondansetron. She has been on doxylamine and she is not responding.
Even
Now
we can
what
get
are you going to do?
Ganisatron mouth dissolving is very effective.
Rifaximin
You can
can
use
What
intravenous
did you
route.
say, Dr. Jayneel?
Ganisatron is also available as a mouth dissolving tablet, and sometimes patients don't respond to ondansetron, but they do respond to Ganisatron. That is more seen clinically.
We can also
Granisatron
do
is there.
metoclopramide. Metoclopramide also we can give.
Also. Ma'am, is small,
Metoclopramide is these days banned drug. Do you know that? It's a
Okay.
banned drug.
Madam,
we
for
can
hyperemesis,
tell
if it
patients
is
for
very severe hyperemesis, then we need to give steroid, madam. For Dexona, we are using Dexona sometimes.
Dexona and promethazine actually does
Yeah,
wonders.
we are using the Dexona.
It does wonders because it takes care of the mental aspect as well.
Yes, yes.
So you've given that, you've hydrated her, nutritional support is given. When do you want to hospitalize her? And when you want to say, ki, you take this medicine and try at home? What is your cutoff when you want to hospitalize her?
Ma'am, first of all, she is resistant to oral antiemetics. She is unable to keep food or fluid, experiencing dizziness and fainting. There's sign of dehydration. She is experiencing weight loss. We should admit her in that case, ma'am. Is scenario.
Or
Okay.
if our investigations show carbohydrate imbalance or ketosis, we would like to admit her.
sensorium is altered.
Yes, ma'am.
Electrolytes are altered.
Electrolyte imbalance.
More than 5%
So-
weight loss.
No, even by
Here-
looking at the patient, madam, even by looking at the patient, if she is looking dull, she is looking or
Sign of
might
negative.
1 to 2 days, what will be she do? We can ask her that get admit for 1 to 2 days if you are so much weak, or by asking the patient, we can decide that also.
One question I want to ask you, it's not written here, but there is a patient who suddenly presents to you in the third trimester with acute fatty liver of pregnancy. Is a history of hyperemesis relevant?
Yes, ma'am.
Exactly.
Yes, it is irrelevant.
It is relevant. So she had hyperemesis in the first trimester. She may present with AFLP later. So you cannot take hyperemesis very lightly.
Yes.
So you have treated this patient, her vomiting is controlled. How are you going to monitor her, keeping in mind that she is a candidate for AFLP? If she has severe hyperemesis, then she's a candidate for AFLP. How are you going to, monitor her?
Again, madam, signs and symptoms should be explained to the patient: nausea, vomiting, abdominal pain, decreased food appetite, weight loss, and she may present with the hypoglycemia, the chakkar and all. Should explain to the patient. And we can, if she is having so much severe hyperemesis, we generally go for elective in hyperemesis in routinely for patient. And
no, that you have done in the first trimester, you've diagnosed. Now I'm talking about what you are going to counsel.
Yeah, we
for
can
the rest
explain
of
the
our
symptoms for
pregnancy.
that to the patient, that any nausea, vomiting, and any type of such symptoms, if you encounter, please come to us. We have to explain, we should write on that discharge card also.
Good nutrition.
Now, so many patients come to us in pregnancy. Chakkar aa raha hai, ghabrahat ho rahi hai. They come at any time in pregnancy. First trimester, second trimester, third trimester. So how are you going to differentiate that chakkar from that chakkar of your liver disorder? Any patient will come, na, chakkar aa raha hai, ghabrahat ho rahi hai, dhad ho raha hai. These are simple things that
we can monitor the vitals, including SpO2 and pulse BP, which will give us an idea. Differentiate.
We'll be doing so.
Serum electrolytes.
A significant history of weight loss is also
level.
Electrolytes level.
And ECG, ma'am.
So every patient who comes to your OPD with ghabrahat and, chakkar, you're going to do electrolytes on her?
Ma'am, random blood sugar we can do.
LFT, blood sugar.
Madam, for liver disease, the weight loss history is important. In pregnancy, we generally routinely we see weight for every patient whenever she comes. So with such symptoms, if there is a history of weight loss, that is a decrease in appetite. That is one of the symptoms for that. Indigestion, decreased appetite, difficulty in eating. That is one of the clinical signs and symptoms for this, madam. We should follow that thing actually.
I feel that these symptoms are common for normal pregnancy also. So this should not be one factor which would take us to liver disease, because normally people will have decreased, like so many patients have decreased, and weight loss can also be because of some fetal condition like IUGR or something. So it might falsely lead us if we think in that direction. That's what I feel.
Ma'am, the
weight
sugar
loss
level
will never be because of IUGR. Never. You have 100 kg patients with 2 kilo ka bachcha. So, you cannot say that IUGR will cause this. What I think that in the first trimester, loss of appetite is normal. But in late trimester, loss of weight or loss of appetite is not normal. Yes. So that should be one alerting factor. And before I take you to the next case, requesting Ruchi ma'am to say a few words.
As you rightly said, ma'am, patient giving history of loss of appetite, feeling unwell, loss of weight after the first trimester, we should look into it seriously and just not let it pass away.
So now this is non-alcoholic fatty liver disease. This is, previously she's a patient 114 kilograms and she has a fatty liver on ultrasound, which she is telling you very proudly ki mera to fatty liver grade 2 likha tha. Now she comes in the second trimester and her tests have worsened. So this non-alcoholic fatty liver disease, does it have an impact on pregnancy? Or does pregnancy have an impact on it?
And both have impact on each other, ma'am. Pregnancy affect NAFLD. She is, ma'am, obese, so insulin resistance will be more in her, and could be more in her. Hypervolemia and inflammatory response can increase NAFLD, and there's increased risk of cardiometabolic disease in this patient. And NAFLD also can affect the pregnancy. It can cause more chances of gestational diabetes, preeclampsia, eclampsia, HELP syndrome, preterm birth, intrahepatic cholestasis. Baby weight could be more, which can lead to shoulder dystocia, respiratory distress. Hypoglycemia could be there after birth, and there's also chances of PPH, ma'am.
Okay, so now here I'm asking you, how often are you going to monitor her LFTs? What is the frequency? A pre-existing patient of non-alcoholic fatty liver disease, how often are you going to do
First
a liver
trimester,
function
madam,
test?
monthly is monthly.
She has come to you in the second trimester. Now,
second trimester, okay.
I would like to do weekly, ma'am.
Weekly, fortnightly, monthly.
Monthly should be enough.
Yeah, madam,
Yes.
symptoms and patient, again, history and seeing the patient and asking her about her wellness and everything, and any deterioration from that thing, we need to go for again for the test, madam. That is for this thing.
Okay, so basically, clinically, if there is a deterioration, you will do
Yeah.
it anytime.
Yeah,
If there is no deterioration, you would still want to do it monthly or
Yeah.
fortnightly.
Yeah.
Monthly should be fine.
Monthly.
But no, ma'am, because I don't agree, because the patients here are very poor, like intelligence-wise. So if you tell them monthly, they won't come for a month. And if they come after a month, they come in a very severe state. So I would think if we tell them weekly, they'll come after 10 days. They never stick to that. Our population, like patients we get, are of very poor socioeconomic status. They come from long, they don't have much cars and vehicles so if we tell them weekly, then they'll come after
Yes,
10
again, this is the planning. If we are having such a VIP patient, then madam, we need to change our plan.
No, agreed. We are talking about guidelines here.
Yes,
So
madam.
how are you going to, this is Ruchi ma'am's question.
Yes.
Are you going to deliver her normally or cesarean section, and at which weeks? How many weeks do you want to carry her?
Madam, everything is right. Everything is good. Then 36 weeks with steroid is not a problem. But anything
Why
deteriorates.
do you want to give steroid at 36 weeks? Why do you want to give steroid? Because see, the guideline for steroid is 28 to 34 weeks.
34 is yes. But nowadays some guidelines and some different papers.
That is only for diabetes where lung maturity is poor.
Yes.
So if the patient has GDM, then you would give steroid even at 36. But otherwise, beyond 34, there is no guideline for steroid.
Yes,
Right.
so we can wait till 36, madam. We can wait till 36. In any other sciences, any other investigations which are deteriorating, then we can, as we have discussed, with steroid 32 weeks is more than enough for any deteriorating factor. Even 30 weeks, madam. Any deteriorating for mother.
So now this patient, she has delivered. Vedi, Dr. Vedi,
yes,
how are you going to counsel her for long-term health and future pregnancy?
Ma'am, once she is resolved with all the liver function tests for her long-term health, the main associated factors is the lifestyle. So she needs to inculcate a healthy lifestyle. Main factor would be reduction in the obesity because she is overweight, and include
she
the
was 14 kg before she got pregnant, right? With a BMI of 48.
Yes,
now
yes,
what
ma'am.
are you going to do?
So, ma'am, weight reduction is one thing which she should focus on. Apart from that, the dietary modification also needs to be done for especially for her. And she should also be counseled that in the long term, she is at the risk of the metabolic syndrome, which is there would be, she's at risk of diabetes as well as hypertension. So she should also keep on monitoring in after 6 monthly monitoring should be done regarding the same.
See, all of us are very well aware that a patient who has gained this much of weight is not very happy losing it. They have sort of mentally got comfortable with the weight they have. And whatever counseling you do, they don't listen.
I think even bariatric
Yesterday I
surgery
had a
should be offered to
Ma'am,
the
she
patient
should
if her
also be
BMI is more than
advised for
38.
regular breastfeeding would also help her to reduce the weight. Exclusive breastfeeding.
That is one thing. Breastfeeding and
yes.
Would you prescribe her medicines to lose weight or not?
Yes, ma'am. I think we should. Like if she's not opting for bariatric surgery, then at least metformin or even semaglutide should be started because it helps in.
So, at what weight would you advise bariatric surgery? What is the cutoff of BMI?
BMI, according to the guidelines, if the BMI is more than 35 and she has other comorbidities, then it should be offered. Like hypertension.
At least 40 is where you would advise her to get bariatric.
Yeah, more than 40 BMI or more than 35 with comorbidities is what the guidelines say. Okay.
So then you would prescribe metformin or?
Semaglutide is a newer drug, ma'am. That can also be given.
But that cannot be given for more than 90 days, right?
No, ma'am. It can be given. The studies right now show that it can be the treatment can be given up to 13 months without any side effects to the patient.
See, there are different papers from Hong Kong where patients lost their lives. Is it not the same drug, or I'm making a mistake?
No, ma'am. I haven't heard of anything patient losing their lives. The main problem that most of the patients face are the gastric reflux and the persistent nausea, vomiting is what happens usually.
Okay, so but you said 13 months.
Yes, the studies.
But again, she would stop at 13 or 15 months.
Yes.
Metformin she can continue indefinitely.
Yes.
But again, metformin is one thing that will only cause a weight loss of 1 to 2 kilograms, maybe 3 kilograms, not more than that.
No, ma'am, this is only a supplement to the regular lifestyle changes that she has.
तो समुद्र में से लोटा निकालने वाली बात है.
Then what are we going to do? I would even recommend that she even undergo liposuction so that her insulin resistance can get better.
What dose of metformin you recommend, ma'am, for weight loss?
Ma'am, you can go up to 2 grams per day. So, Sanjita, would you like to say something? I want a take-home message. We've already exceeded the time. One take-home message from everyone before I end the session.
Ma'am, liver disease during pregnancy can be complicated to manage, and it requires a multidisciplinary approach. Broad vision for early diagnosis is very important for both mother and baby. Ma'am, thank you for taking this topic in this webinar.
Thank you. I know everybody must have had to study a bit because we don't usually, we get jaundice and we call in a gastroenterologist.
Yes, ma'am.
And that's what mostly happens.
Madam,
Dr. Ashish?
I have one thing, madam. My teacher used to say that when we see a patient, no, the first thing we have in the mind, then the second thing we think, no, it is a false. So always think the first thing what you think. Try to think that also.
Okay. Meena, ma'am?
Ma'am, first of all, you are amazing. I'm your fan. You are so crisp, concise, concrete. And you can be followed like a book. And the topic was so good. You make me read. And I would just say one take-home message. It should be multidisciplinary approach. Neonatologist, fetal-maternal medicine person, hepatologist, don't take on your head alone. Obstetrician, physician for diabetes, cardiovascular disease, etc. So nurses, midwife, everybody should be, and the patient and the relatives. They should all sit together and talk about it.
Thank you, ma'am. Dr. Vedi?
Ma'am, it was a very nice session. One take-home message I would like to take is that since I am more practicing into IVF, so the amount of progesterone which we give, that is one we need to keep in mind. That was really alarming.
That is thanks to Ruchi, ma'am.
Yes.
Thank you. Dr. Mohit and then Dr. Jayneel.
So the first take-home message for me as a doctor, like because of this panel, I did, as you mentioned, I did some studying into liver disease, because we don't get so many cases of liver disease. And whenever we get a liver disease, it is just, when will you terminate? When will you terminate? That's the only point of thinking. But by doing all this study, the research, I got to know many things about the drugs which we can be given, what else can be given, who all we can collaborate, and how can we make a decision apart from termination regarding the disease itself. So I'm very thankful for that. And for the disease, like liver disease in pregnancy is increasing because of the lifestyle changes. The liver disease were not very common earlier. Right now, because of the lifestyle changes, they've become more common, and we need to be more aware of them, because they will come in more frequency in the near future. So we need to be knowledgeable about that. Thank you so much, ma'am.
Thank you, Dr. Mohit. Yes, Dr. Jayneel.
Yes, ma'am. So this panel, yes, you rightly said that we did have to read up a bit on it. And yes, and as obstetricians, we don't go into much details of it, the pathogenesis and what exactly how it occurs. But such a good, healthy discussion we had with all other obstetricians and gynecologists here. And it's good that we could conclude on some certain facts, and that is what the take-home message is for me.
Thank you. Dr. Munjal, are you still there? He's there, but he's not there. So, Dr. Ruchi, I come back to you for the final take-home point before I thank everyone and end the session.
So all friends who are present here, this is one reason to follow Searchlight very regularly. Because whatever topic, even I had to read up this topic today because I was participating in this discussion. So whatever we are reading, it is only adding to our knowledge and how we are going to manage our patients. Now what happens is, the moment you see an LFT report, gastro ke paas chale jao, hepato ke paas chale jao. We are all basically MBBS, तो हम लोग सब लोग हैं ना. So why are we giving up our basic sciences? है ना, जैसे without clinical examination, jump to investigations. Why? So let us build up on that. Let us see. अब आज जो पढ़ा है, it is registered, because we have discussed, when we hear others speaking, it registers more. So now next time we get a patient with liver disease, we will all be set into thinking. Our brain will start working. कि let's look at the liver report. क्या कहती है? Symptom क्या है? पहले से है. So I think this, that is why it is important to participate in these webinars. It hardly matters how little you know or how much you know, but when you hear some inputs from others, that's where your knowledge increases. And life is a learning process. We learn from everybody. हर किसी से आज कुछ सीखे हम लोग. So it is very important to be, and injudicious use of drugs, we have to be very careful with that. We have to monitor our patients. It is not a question of mega test or sasta test where we need an investigation, we need to counsel, we need to get it done. Because finally, at the end of the day, mother may be fine, we are happy. That's what our target is. Isn't it?
And if the mother is not fine, we might end up paying that much more to the consumer court.
Because in obstetrics,
that will be absolutely disproportional to the price of the test.
Because mortality in obstetrics is just not acceptable. So we have to advise, counsel, put it in writing. Then it's up to the patient. If she can't get it done, it's okay. But at least our conscience is clear that we have guided her well, and the patient is aware that, well, I have been told to do this. So next time, if she comes with a problem without that thing getting done, she knows she's at fault and she cannot blame us for that. So we should write, counsel, and follow our, not indiscriminately. Be rational about what you are writing.
So,
Asha ma'am, it is always a pleasure to
for me, Ruchi ma'am, was first thing I learned a lot. The other part is that, everything that our patient is presenting with is clinical. We need to brush up on our clinical skills. It is those clinical questions, the clinical examination, that will trigger everything else. So let us remember and not disregard that, this patient is psychic, ye natak karti hai, this is this is that. Let us not have that mental setup. Whatever the patient is presenting with, that is the history she is giving us. And we, if at the end of this webinar are able to remember the clinical signs and examine the patient, we will be able to know how she is worsening even clinically.
Yes.
Supposing she cannot afford all the tests. So, let us brush up more on our clinical skills, on our clinical knowledge, and then apply it to the investigations. So thank you so much. Thank you, Dr. Ruchi. Thank you, Bharti ma'am, Dr. Munjal, Meena ma'am for volunteering. You know, Dr. Meena Garg, she volunteered, and Sanjita. These are two volunteers who volunteered to be in my program. So thank you so much. And
Thank you,
Dr.
ma'am.
Vedi, Dr. Ashish,
you so
Dr.
much,
Mohit,
ma'am.
and Dr. Jayneel.
Thank you so much.
Thank you.
Thank you,
Thank you, ma'am.
Sujayasri, all of you for spending a wonderful evening with me. See you again next week. Another topic in Searchlight. Namaskar.
Thank you.
Shubh Ratri.
Always a pleasure to be with you.
Thank you.